This conference will now be recorded.
Can you hear me? I think you're on mute.
Can you hear me now?
I can.
Is it clear?
Yes, it is.
Lovely. Nice to meet you.
And you, are you speaking today?
Yes, I'm the first speaker today.
Okay.
Actually, I'm from Brunei, so it's almost midnight for me now. It's 11 p.m.
Oh dear, it's about 4 o'clock here in the afternoon.
Yes, yes. And she told me that. I actually expressed my concern, and she said, "Don't worry, I'll slot you as a first speaker. Otherwise, you're going to wake up through the night."
Oh, crikey.
Yes, and I'm going back to work tomorrow. Got my lasers tomorrow, so I request that. Been very kind, actually.
What's your presentation on?
I'm going to talk on toxic keratitis. This is going to be on for the allied and optometrists, something which is light to make them understand about this entity. The target audience is essentially non-ophthalmologists, isn't it? Mostly allied and optometrists, isn't it?
That's my impression. Yes.
So that's what I'm targeting. So I just make it light for them so they know about this entity. It's especially clinical and also something practical for them.
Yes. That'd be nice.
And are you speaking today as well?
I am at some point. I'm talking about eye dominance.
Lovely.
I don't know if I'm going to shuffle the program around a bit, so I'm ready and waiting.
When you record it. So where do you work? Where do you work?
Oh, in the UK.
Yes.
Near Birmingham or Leicester, to be precise.
I see. Okay.
Do you know that?
Yes. I've been to Birmingham 2 years ago. I got a couple of friends there. Yes, that's right. How's the weather now?
Brilliant.
Lovely.
Beautiful sunny day.
Great.
What about you? I suppose it's sunny all the time.
Yes, here it's sunny and rainy. Sun and the rain here in Brunei. It's always it's a equatorial climate, so it's nice and warm. I hope we all can get over the COVID virus.
Well, I hope so. How are things there?
It's very good. It's well under control, and the borders are locked. So borders are locked. So anyone coming in is in quarantine. So by God's grace, for here, we don't have any local transmissions for the last more than a year now.
Right. Has everybody had? Sorry.
Yeah, so far the mortalities in Brunei so far from the time of COVID starting has been only 3.
Oh, 3?
Yes, 3.
3 people have had it.
3 people have died.
Okay, yeah.
And around 300. Actually, there was a small outbreak in the community first, which was immediately curtailed, and after which they locked the borders. And this is a small place, so easy to control the borders. Yeah. And so who was coming in is getting quarantined for 2 weeks. And so there's been no local transmission by God's grace and no community spread for the last more than a year now.
Oh, well done. And has everybody had?
Yeah, they're starting the vaccination now. Starting is slowly. We, as of now, have only AstraZeneca and Sinopharm. So we've not yet got Moderna or Pfizer into the country yet. We're waiting for that to come in.
So you've controlled it without injections, just by isolating the country?
Yes, that's right.
Crikey.
And so here it's a kingdom, so it's under good control. So people
Yes.
live in, and we just have one airport that is locked, and then the borders. We have 3 airports of entry, which is locked easily, and the seaport is only 1 or 2. So again, that's locked. So it's easy to control.
Don't you feel a bit locked in?
Well, considering the safety, I think we consider ourselves lucky. Actually, we can't travel anywhere. We find it more unsafe outside the country than being inside the country at this point in time.
Yeah. Yeah.
So, I'm so sorry for interruption. So just wanted to confirm if you all can hear me. I'm so sorry, like I just had a technical issue. So just want to confirm if you can hear me.
Yes, we can.
I can hear you.
Thank
can hear
you. Thank you for the confirmation. So I thought like you could hear me and I was speaking till now. So I'm so sorry for that. So
No,
let's just start the session. So let's start our today's session. So let me just give you a quick introduction about myself. And my name is Jessica, Conference Secretariat at. Okay. I please request you all to please unmute. So that, yeah.
You've gone a bit quiet.
Yeah. So my name is Jessica and I'm Conference Secretariat at Coalesce Research Group LLC, and I'll be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. So for the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also the further instructions. So Coalesce Research Group LLC is very delighted to welcome you all, the speakers, supporting associations, students, and delegates present virtually with us today, with the aim of mark the scientific excellence by facilitation, conversation, sharing knowledge. Coalesce Research Group follows through the objective of setting standards and delivering excellence in the research among the researchers, academicians, and industries, promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, engineering, and technology. Within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people across the world from their respective fields that they haven't connected in a while. As a global scientific event organizer, we plan and carry out international conferences, meetings, seminars, symposium, and workshops, providing the best delegate experience, excellent networking opportunities, conversations leading to innovations, learning new opportunities, lasting. Oh, yeah. Thank you. So, learning new opportunities, lasting working relationships, and professionalization with the professionals around the global network. Just recently, we have also started our own platform for open access peer-reviewed scholar literature, where all the content is freely available without any charge to the reader. And we'll also send you the details about our journal so that you can just go through and let us know if you'll be interested in publishing any of your articles over there. So finally, I would like to thank the attendees and participants of today's webinar and hope you enjoy the webinar and gain knowledge from the sessions today. So we also hope your participation will contribute to new research findings and that will lead to new collaborations and research initiatives. Before we start the session, I guess some of you will be new to GoToMeetings app. So let me just explain some important tools required for your presentations. So on the GoToMeetings app or web page, you can find 4 icons at the bottom center, that is the mic, camera, screen, and end. So the mic, you can just click on that to mute and unmute. And I request you all to please stay muted while our speakers are presenting the research work so that it doesn't cause any disturbance to them. And coming to the camera, you can use this button to share or unshare your web camera. If you have the option to share the webcam, you can do it, and it's completely your choice. So the next button will be the screen. So you can use this button to share your screen. And this is the main function, because this will help you to share the screen with us. So after I call your name, from my side, I'll be making you the presenter, and only I can give you the permission for you to share the screen. So only once I give you the permission to share the screen, then you can click on the screen button so that you'll be able to share your screen. So I'll just help you out with that while your presentation. So the final thing, end. So this is the fourth icon where you can just use this to leave the session. So on top center, you can find the options to change your display settings. So at the top right corner, you will have three icons, that is people, chat, and settings. In that chat option, you can chat with me or any other participants. For the settings, you can use this button to check for the settings of your speakers and microphone. So as mentioned, kindly remain muted during the presentation so that the presenters do not get disturbed. And for any questions, you can ask the questions at the end of their sessions. So, well, let's not take much of your time. Finally, I would like to request you to please give us a brief introduction about yourself before starting the session so that we can know about you virtually. And now, let's move on to our sessions, and our first presenter is Dr. Azimuddin Azim Siraj from Ministry of Health, Brunei, Darussalam. So yeah, let me just make you the presenter. Yes, doctor. Please do click on the screen button now so that you'll be able to share your screen with us.
Okay. Can you see my screen?
Yeah, perfect. We can see.
Okay, lovely. Okay. Hi. So my name is Dr. Azim. I'm a consultant ophthalmologist working in a hospital belonging to the Ministry of Health. I am the lead consultant and I lead my team of doctors and nurses and the staff. I'm also an adjunct lecturer to the University of Brunei Darussalam, and I oversee students in undergraduate and also for nursing and allied specialties. I am a regular invited foreign faculty for international conferences and also as a guest speaker and for panel discussions. So my interest is comprehensive ophthalmology. I'm also interested in preventive ophthalmology, and my passion is teaching. So I'm very glad to be here, and it's a pleasure to be with you all here today. And warm greetings to you from the warm country in the equator, Brunei Darussalam. So without much ado, can I go ahead in the presentation, please?
Yes, doctor, sure.
Okay, lovely. So today we're going to have a discussion, a short overview about a topic which is used most commonly underdiagnosed and easily missed. And this condition can cause a lot of morbidity for the patients, and if not treated on time, can even lead to permanent damage to the eye, toxic keratitis. Toxic keratitis, today at the end of the session, probably the objectives would be that the learners, we can learn what is toxic keratitis in a brief overview and in relevance to the concerned specialties. We'll also see some clinical pearls and management principles and brief treatment and take-home points. Toxic keratitis encompasses a group of these varied disorders due to affecting of the cornea because of a different spectrum of toxins of varied etiology. As allied specialties in optometrists, why should we know about this condition? It's essentially because you could be the first person whom the patient is going to meet in the part of your profession. They could be coming for refraction, but they might be having a chronic red eye or disturbance. And you could be the first person to alert the ophthalmologist about this condition. The basic treatment is very simple: identify and take the cause and stop the medication as the patient becomes very comfortable. You'll have a very, very grateful patient if you can pick this up on time. So that's the reason why, and there have been a lot of literature reports about this condition which has been underdiagnosed. And historically, even the papyrus has such documentations. Basically, the toxins affect the cornea after bypassing all the protective mechanisms which are already existing in the eye. The etiologies can be physical, chemical, biological, and miscellaneous. So let's see them one by one, quickly and briefly. The physical ones include contact lenses, trauma, and any foreign bodies which have toxic metals. So if these patients have this and not removed on time, these toxins can affect the cornea permanently. Temperatures like heat, firecrackers. Firecrackers not only hit the eyeball, but the temperature and also the chemicals in the firecrackers can cause damage. Similarly, microwave popcorns with children, they look into the popcorn bag to see if it's really puffed up and it suddenly explodes into the eye. Open frames are better because they stop temporarily and the patient comes out of it, whereas hot objects or liquids can be disastrous because as long as those are in contact, this damage can happen. So basically what do you do? When you see radiation, it can be ultraviolet or infrared, a part of profession, a part of accidents, a part of hobbies. Ultraviolet light usually causes superficial lesions like pterygia or OSSN. However, infrared can cause uveitis, cataracts, and miosis. Radiation, of course, depends on the contact time and the severity of the agent. So remember always to rule out life-threatening conditions before you start treating this patient if you're going to be the first person on site. As far as you're concerned, when you see such a patient, this toxic agent has to be immediately removed. If you can at your site, please. And a copious lavage is done immediately with an antibiotic cover and lubricants before being sent to the ophthalmologist. The initial time is the essence of the treatment of such conditions. It can happen because of physical damage to the breakdown of the anatomical barriers with secondary infections, which can happen later on. That's why. You should remember again not to confuse with the central toxic keratitis following refractive procedures. This is physical for you. Chemical agents. Chemical agents can be solids, liquids, gases, or venoms. Solids actually can be lime. This is very common, especially in people working in the construction factories. Liquids can be acids or alkali. It's been traditionally taught that acids are less dangerous because they can form a barrier. However, the exception is hydrofluoric acid, which can reach inside the eyeball in seconds. So whenever there's an alkali, which can saponify the cell membrane and go into the eye, or a very strong acid, first of all, remember it's an emergency. When you evaluate these patients, when you see here, you'll be able to see that these patients have will be having some kind of epithelial defect here, and later they will have ischemia of the limbus. This is called limbal ischemia. If you can see whitening, that's not a very good sign. And later on, more severe stages, you'll see the ischemia and also the corneal epithelial damage. And in really worst cases, the whole of the eye looks white. It may look innocuous, but this is the most dangerous eye you can have. So this is a medical emergency, ophthalmic emergency, which needs immediate treatment. So what do? This can be graded according to different grades as per the Roper Hall classification or as per the Duas classification which came up later. Three things you should look out for. The first thing you look out for is the cornea. Is it clear? Second, look for the limbus to see the amount of whitening, and look for the conjunctiva. The more they are white, the more urgently they need a referral. So can you do anything from your side? Of course you can. Remember, the history is very important. Sometimes people working in the vegetation, chemicals, when they cut plants, some plant sap, or some traditional procedures where they try to use some seeds to clean the hair. These kind of things can cause not only mechanical debridement, but also can cause chemical damage to the structures. So whenever you see such things, immediately you have to wash before the ophthalmologist sees the patient. So in your specialty, you might be working in a peripheral hospital with ready access to ophthalmologists, or you might be in a peripheral center, which takes some time for the patient to reach the hospital. Please do a copious irrigation. That's what you can save the patient's eye. Copious irrigation, lubrication, and if possible, antibiotics. Please remember not to use steroids because it can cause secondary infections. Gases can be because of warfare or can be because of accidents. Gases can be deeply penetrant into the eye, and sometimes they can cause anterior segment structural damage. It can cause uveitis, or it can cause glaucoma in late stages. However, in the acute stages, it can just melt the cornea and cause damage. So we saw solids, liquids, and gases. So the essence of this is remove the patient from the site of the injury, clean with all the mechanical debris whichever is stuck there. Copious lavage, we recommend 30 minutes at least of continuous irrigation, and an antibiotic cream and a lubricant if possible before the patient can be sent to the ophthalmologist. This is something which is more common in tropical countries, venoms. Well, they can be bees or wasps. The bees are acidic and the wasps are alkaline. Both are equally dangerous. What you should look for is these venom stings which are present here. When they bite and they hit the eye, they tend to see the cornea and they sting the cornea. When they sting the cornea, this particular venom sting gets into the substance of the cornea. And that's where it becomes dangerous, because it becomes like a sponge slowly exuding the toxins into the cornea, which can cause necrosis. So when you see a patient with this history, get them onto the slit lamp, look for the sting, and if possible, under local anesthetic in a sterile forceps, if you can take it out, you're doing the patient a lot of good, because this is what is going to prevent a further long-term damage. Most of the time, the toxin is caused in these venom stings, and because they're present in the cornea, they can cause irreparable damage both to the stroma and also to the endothelium, sometimes even leading drastic procedures like penetrating keratoplasty and long-term anterior segment damage. So remember, whenever you get it, look for it, remove it, wash it, antibiotic, patch, and immediately refer to the ophthalmologist. And that will be life-saving because time is the essence. We also have sometimes a group of snakes, snake venom. Some of the snakes have this kind of a protective mechanism to ward off a threat to them. They do not bite. They can bite, but what they do is when the person comes close to them, they exude the venom like a jet spray. If you observe here, the one on the left, the fang on the left has a linear spike. This belongs to the snakes which can cause death by biting. So the venom goes deep into the substance of the flesh. However, when you have these kind of fangs, these are the ones which are spitting venom, spitting cobra. This is anteriorly placed, and you can see it's almost like a water jet, a small rounded one. So when the venom is injected very, very strong, with strong, powerful force, this forms a small jet. In fact, the jet is so powerful, it can even reach 8 to 10 feet in distance. So the snake looks at the patient's eyes and targets this venom on the person's eyes. It can be an animal, it can be a human, whatever it considers as a threat. The snake tends to squeeze this venom onto the particular person. And if you can see the gland here, this is muscular. These snakes have glands which are having a muzzle. So it's almost like a jet. It squeezes the venom, goes out through a small hole, and comes like a spray. And as it is spraying, it doesn't remain still. It keeps moving its head like this. So the spray covers a more bigger area. This has been documented way back in 1944 by our own Harold Ridley, the gentleman who was responsible for the intraocular lenses. So this is there for long, and we've had cases reporting to us with spitting cobra venom. So how does this actually happen? So here we see we'll try to see if the video plays. Here you have the snake looking at the object, and as it's targeting and it sees the person who is actually, when they see the target, it tries to focus on the person's eyes. When it focuses on the person's eyes, it tends to, let me try to get it back again. Let's see if it plays again. Okay, so the snake tries to target on the victim, and it tries to squeeze out. If you can see, a jet is coming out. So this is how it sprays on the eyes, targeting the eyes. So when the spray is happening, the force is so strong, and the spray jet causes so much of irritation into the patient's eyes. So the person who's trying to come to catch the snake is stalled. They don't move, and the snake has time to escape. So in the snake venom, we have neurotoxin, cytotoxin, and cardiotoxin. It is this cardiotoxin that is dangerous for the person because it can cause membrane lysis and cause corneal damage. Luckily, this one cannot penetrate the stroma, so it stops superficially. It doesn't go deep into the eye. So on treatment part, apart from the wash and copious irrigation, which is the first aid for such conditions, we have cardiotoxin binding heparin at 2,500 units per ml. So this is what is given in topically to reduce it. These patients will not require any anti-venom intravenously, and steroids are contraindicated because it can enhance collagenase. So this you might or might not encounter these cases in your practice, but in case you do, nothing to panic, nothing to worry. Reassure the patient, wash well, continuous irrigation, and antibiotic cream before you pack the patient off to the ophthalmologist. Our patient resolved very well. Within 5 days, the cornea was just hazy, cleared up really well, and the patient was very comfortable and the vision came back to normal. Iatrogenic. This is something which you should know because these are a huge chunk of patients who are having ocular problems because of the medication we are giving to them. This chemical damage can be occurring because of either systemic problems, because of medications like EGFR inhibitors, panitumumab, where it can cause corneal melting, or amiodarone, which can cause deposits on the cornea, or it can be because of local medications. This is more common. Local medications can be because of ophthalmic medications or because of medication errors. Ophthalmic medications can be because we have found that most of us, to be sorry, when you have a case of a corneal ulcer, we just try to hit the maximum power. Even unfortunately, in some centers, even for conjunctivitis, they go for the highest broad spectrum antibiotic. This actually causes damage because these strong chemicals and the preservatives can actually cause corneal damage, especially if more frequently introduced. We have a spectrum of causes, and the most common culprit is also glaucoma medications. If you notice some of your glaucoma patients coming to you, most of them will have red eye, especially if they're on prostaglandin analogs or if they're on primordial. Sometimes it can be because of medication errors. This is from the Saudi journal, where there's a medication called Tobra Tex. They give Tabinex, which is a topical diclofenac jelly, which was applied into the eye without the patient's knowledge, with an ignorant patient, and he landed up into corneal problems. Of course, he was lucky to be saved, but it can happen not only because of our medications, but because of pharmacy errors. So all of us should be individually responsible to be more careful to the patients. What happens? Basically, the offending agent can cause corneal damage, punctate, or it can also be indirect damage. How can it cause indirect damage? Indirect damage can be because of immune response. What happens in immune response? The body tends to fights the medications, and it tends to consider that as a foreign enemy. So it sends in neutrophils and limbal stem cells, and these come and exude their own cytolytic enzymes, thinking they're going to do good, but in fact it causes a damage to the cornea itself. So both direct and indirect damage can be happening because of medicamentosa. The treatment for it is mostly to avoid and change that medication, and most often than not, go for preservative free. You see, moxifloxacin, so commonly used, that has also been implicated in corneal changes. So whenever we have to be responsible when prescribing for medications, we have to be very careful what medication we are prescribing. Remember, inflammatory necrosis of the cornea is common and later can lead to vascularization and also scarring. So these are the pathophysiology of how things can happen. This should always be in our mind when we are prescribing. These were chemicals for you. Well, infections itself can cause damage. Bacteria, viruses, fungi. How can they cause damage? Well, these organisms directly cause damage. Secondly, they exude some enzymes and toxins as they're being dead. Third, the body's autoimmune response also brings in neutrophils. It brings in MMP. It brings in autoimmune response and all the cytokines. These of them can actually cause damage. So the damage by the organism itself, by their released toxins, and by the body's reaction to them. To make things worse, the medications we're going to give for treatment, we give them hourly, half-hourly antibiotic. They can also cause further damage. And the preservatives in those things can also make it worse. So you have one leading to the other. So the eye becomes so red, you do not know if it's an infective pathology going bad or the eye is just reacting. Is it a sterile ulcer? It makes the picture so complicated. So it's very important for us to note how things are progressing and monitor these patients very closely. If they come to you in your practice when the condition is getting bad, it might be worthwhile for you to call the ophthalmologist and alert them about this condition, because sometimes the ophthalmologist would have given a review after 5 weeks, 4 weeks, 3 weeks, and then they might not know these things are happening. So you might be the person to alert the ophthalmologist, and when you alert the ophthalmologist, you know that this fluctuation can be controlled on time. Okay, right. So remember always, these can also lead to late sequelae. These patients are never said bye. They have to come back to you, because they can have long-term sequelae like dry eyes, cicatrization, sembliférons, corneal scars, etc. So whenever you see a patient having a severe kind of reaction to the eye, please ensure they come for follow-up and make sure the patient is on good lubricants. This is what you can do. Well, so now that since you've come across this quickly, let's have a quick recap from your point of view, how this is relevant to your practice. Remember, first, all of these have common clinical features. Okay, what are the common symptoms? These patients will complain of redness, pain, watering, epithelial defects which are not healing, drop in vision, and that's when they come to you, and symptoms of inflammation. How do you suspect it? If a patient of conjunctivitis, for example, a patient of corneal ulcer, for example, patient was taking medications, they started getting better. After a week of they getting better, new symptoms start coming in. Then you know this is not the same condition getting worse. If the patients did not get better, they got worse, in spite of medications, then you can suspect that the clinical condition is getting worse. But however, if the patient got better, the eye was getting comfortable, patient's vision was improving, then slowly they start getting a SPK-like picture. When you stain them on your fluid in the stick lamp, you see corneal spots. And generally the conjunctiva is congested. The ulcer is there, but it's not healing. Maybe this is secondary to the preservative, so that's preventing the ulcer from healing. So these are the red flags which you find out, which you can alert the ophthalmologist that this is what the patient comes to you, because they will come to you with drop in vision. They might not go back to the ophthalmologist. So when they come and you stain and you find this, it's a high time to alert the ophthalmologist. This is how you suspect that the patient probably is having a toxic, or you know with the history something fell into the eye, you know from the history. So history is very important for this condition, for you to know. One is to identify, two is to document it, and three is to assess the progression of the disease. What are the signs? When you're going to examine these patients, there'll be congestion, circumcorneal congestion, epithelial defects, fluorescein stain will be stippled, more diffuse. Medicamentosa patients, remember, always the lower half of the cornea is involved and the lower fornix is involved. Why? Because that's where they put the drop. Most patients have the habit of putting drops at the same time, at the same place. So sometimes we tell our patients when they have them frequent, we tell them to alternate the place of putting the drop. One time looking down and putting up, one time looking up, and we encourage the attender to put the eye drop so the drop doesn't fall on the cornea at all times. Remember, fluorescein stain is useful for documentation and also for follow-ups. Endothelial changes could be there. There could be some inflammatory signs as well. These are the red flags which make sure alerts you to talk to the ophthalmologist. Stains and culture, usually these are culture negative. Common treatment options. Again, I'm making it simple for you. When you have a patient coming and this common, whatever it could be the cause, remember to remove the offending agent. Copious lavage. If chemical injuries, 30 minutes. Generous lubrication, whatever, preferably anything which is preservative free. Cycloplegics, optional. If there's inflammation, depends, leave it to the ophthalmologist. Antibiotics could be safer. And a bandage contact lens is optional, plus minus, depending on the epithelial changes. Steroids, better you don't touch. So this is how we are considering and we think of managing such patients. What else can you do? There's specific treatment options. Treatment options include frequent artificial tears, jellies, autologous serums, ocular surface protection. These are the ones which are done for more advanced cases under the ophthalmologist care, oculoplasty care. But this should not happen when we are catching them on time, and if you refer on time, when you treat on time from your side, you will be able to support us so that we don't land up in this condition later. Sometimes they may require lid surgeries and treatment for uveitis, glaucoma, and cataracts. So what are the take-home points which we can pick up from this lecture? Remember, it is actually preventable. The cause, you have to look for it. And if possible, always let's go for preservative-free medications. The dosing is important. Let's not over-treat a patient. Catch the patient, treat the ideal condition, educate the patient to the technique of putting the drops. These are very important. Triggers, patient education is very important. Early detection from your side, patient education, GP awareness, not to over-inculcate patient. Prompt treatment is important. And we have to prevent recurrences, especially these UV-induced, job-related induced, safety goggles, protection in chemical injuries. So employee education, patient education, prevention, because these are all disastrous complications which can happen. So you should remember that toxic keratitis is a great mimicker. All it needs is a high index of suspicion, timely intervention, and a lifelong follow-up so that this is no longer a danger to be worried about. Thank you very much.
Thanks a lot, Dr. Azamuddin. It was really interesting and informative too. And so now, do we have any questions for Dr. Azimuddin regarding the presentation?
Hello, are you clear?
Yeah. So just wanted to know if anyone is having any questions. Could you hear me?
Is it clear? Hey, anyone?
Yeah. So any questions? Okay, I guess there are no questions. So thanks a lot. Thank you for your time and your presentation. Could you please confirm if I am audible to you all? Because I'm not sure. You are audible, Dr. Azimuddin.
You are also audible.
Oh, thank you. So, yeah, I guess there are no questions. So now let's move on to our next session in that case. So, yeah, we have Dr. Jerian Griffiths from the Association of Sport and School Vision Practitioner, United Kingdom. So let me just make you the presenter. Yes, Dr. Griffiths, please do click on the screen button so that you'll be able to share your screen with us. Dr. Griffiths, could you please unmute? Yeah, your screen is visible to us.
Yeah, I found it.
Yeah.
So I want to start with just a few words of introduction, and I've got 1 or 2 slides to bring up onto the screen, which I hope will emerge when I press the PowerPoint slides.
Sure.
So just as an introduction, I'm an optometrist in the UK with an interest in binocular vision and its application to sport and school vision. So it's to do with reading difficulties particularly, and in sport, towards sporting performance. And what I want to introduce today is the concept of measuring eye dominance. Now, the way in which we've learned to adapt and interpret the physical world is, I think, one of life's miracles. Vision is fundamental to our understanding, so it's constantly surprising to me how much we take our eyes for granted. Not our last speaker, by all means, who's obviously very concerned with the health of the individual eye and the 2 eyes, but in optometry, we're in a sense more concerned with how the eyes work together, and particularly understanding that each eye has a separate function. The dominant eye is the one which gives us our spatial awareness, tells us where we are in relation to other objects, and the non-dominant eye, which is established after aiming or positional sense is established, is the one that allows us to judge depth. So both eyes have a different role in that sense. And it's understandable why most people take this for granted, because we see one vision of the world, even though the brain is suppressing a doubling effect on each side. The cleverness is that we see one object. Now, what's interesting is that in optometry, this has really caused a problem, and that is that although we can measure vision till the cows come home, we can't relate our vision correction to its effect on occupational performance or sporting performance. And hitherto, there's been no scientific model in which to show that association. Now, given the importance of eye dominance, it may be able, through that understanding, to allow us to create a scientific model to establish this connection between visual performance and sporting or occupational performance. Now, I just want to see if the first slide works now. If I press that, can you see the slide?
Yeah.
Yes,
It's visible.
Is it full screen or just?
Oh no, it's actually like. Yeah, now it's perfect.
Okay. Now this is a slide which shows research in sport vision, illustrating the incidence of eye dominance and hand dominance. For instance, people who have a right eye dominant and a right hand dominant, others who have a left eye dominant and a right hand, for instance. So there are 4 separate configurations: right, right, left, left, right, left, and left, right. Now, if you look at the incidence of these characteristics in different sports, you can see from the slide that it varies from one sport to another. And in archery, for example, 62% are right-handed, right eye. In cricket, it's less. In football, it's slightly more. But in rifle, it's nearly 90%. Now, the question this begs is, does this configuration, is that important in each of these individual sports? Is it a coincidence that there's such a high incidence of right eye, right hand dominance in rifle and much less in cricket? Now, that led to the thought is, what if we upset this relationship between the 2 eyes by, say, blurring the dominant eye? Now, I just want to go back to me now, if I can. So the hypothesis was, let's see what happens if we blur the dominant eye in 2 particular sports. And the 2 sports we had at the time were clay shooting and tennis. Now the way in which we blurred the eye with these 2 groups of people was that we used some what's called Bangada foil, which is a clinically degraded piece of plastic which is placed in front of one eye to lower the vision to about 615, which is about the driving standard. And we gave these 2 athletes 2 sporting tasks. One for the shooters was to hit a clay at roughly 30 meters, coming directly up in front of them. And that's a pretty easy target for a clay shooter. And we scored their success by giving them 1 point for a hit, no points for a miss. Now with the tennis players, we asked them to stand on the midway line of the court to receive balls from a ball launcher and hit them against an archery target, which is separated into colors. So we were able to score their hitting rate. For instance, if they hit the middle, it was 3, inner ring, it was 2, outer ring 1, and a complete miss, none. So in both sports, we had a means of scoring their sporting performance. And we did this in 3 conditions. One with the right eye blurred with this piece of foil, one with the left eye blurred, and then a control condition with no blurring. So we had a means of scoring their sporting performance in each of these conditions. Now, when we look at the results, and I think if I can bring up the next slide, if this works. Make sure I get the right presentation. Now, I'm hoping you're seeing the whole slide at the moment. You can see when we look at the condition where there was no blur, this is for the shooters, against the blur of the dominant eye, for the whole group, there was no significant effect on their ability to hit the target. But when we separated these players into what we have subsequently called type 1, which is right eye dominant, right-handed, right leg, right everything, and type 2, which is any tendency to left eye dominance. So it could be a right eye with a left hand or a right eye with a left leg. They both appeared physiologically different in their ability to hit the target. In type 1, for instance, you can see that the chances are that they're going to miss the target is significant to the extent of 0.0057. Type 2 were relatively unaffected. Now, it's interesting that type 1 were the best shooters. Certainly in clay shooting, it's an advantage to be right eye, right-handed. So that was the first thing, and that was the first little bit of evidence which directly connected vision and sporting performance. And that we found that when their dominant right eye was blurred, they found it very difficult to hit the target. Now, in the tennis players, we found this, that in the whole group, both were affected, whether it was their non-dominant eye or their dominant eye, although the effect was greater when the non-dominant eye was blurred. Now, when the group was separated again into these type 1 and type 2 players, it was the type 1 again who were most affected by this effect. But interestingly, it wasn't their dominant eye which caused the bigger difficulty, it was their non-dominant eye. So there's two different sports here which behave differently when the vision is blurred. But what the interesting thing this raised, of course, is that first of all, we were only able to discover this by isolating these two types, type 1 and type 2. Type 1, right, right, right. Type 2, any left tendency. But in both cases, for type 1, when there was a little bit of blur in either the dominant eye or the non-dominant eye, it affected their sporting performance. Now, this amount of blur would be equivalent to a little bit of early short sight or uncorrected astigmatism. But it shows, first of all, for the first time, we think that vision and sporting performance are directly related. Now, from that, it follows that in shooting, the primary visual skill is aiming, the ability to aim at a target. But in tennis, it's the non-dominant eye which is critical. Now, so the non-dominant eye is the one that allows you to judge depth. Now, although in tennis both eyes are to some extent important, the non-dominant eye is the most important. Now, we know tennis is a game where the targets are very straightforward. It's just the other side of the net. In shooting, it's a very small object, 30 meters away, which is about 11 centimeters in diameter. So the skill in tennis is not aiming as such, although there is an aiming component. It's the ability to judge depth, to see how far away the ball is, so you can judge when it's going to arrive in order to be able to hit it. So we've been able to deduce from that that there are two primary visual skills in sports, and that by implication all occupations. One is the ability to aim, and the other is the ability to anticipate an event by judging depth. So aiming and anticipation. Now you can say then, if you get any group of athletes, if they have a problem in any one of those skills, that there must be some difficulty in the primary diagnostic elements of visual performance. Now, the remarkable thing that there are only 6 of these. It's not a whole panoply of tests, it's 6 simple tests. And when you see a problem in someone who's presented saying they're missing the ball or mistiming the ball, you have to look to the 6 primary visual skills, which are high and low contrast logmar vision, eye dominance, fixation disparity, which is a measure of how well these two images are combined in the visual cortex. There's a simple test to do that. Color preference, muscle balance, which is generally how the eyes work together, and finally refraction. So the chances are, if they have a problem, it'll be one of those diagnostic tests which will need remedying. And what we're saying is that now we've directly connected vision and sporting performance, that by making that correction, and it is just simply with spectacles and or contact lenses in conjunction with those things, we can stop this visual problem. Now that's very straightforward because it's an alternative to the general understanding with athletes who have difficulty with any aspect of their game. It's generally thought that, well, if there is a problem with the eyes, it's probably muscular, and maybe give them eye exercises. The trouble is, this has become a sort of panacea for a team. If you're off your game, you give everybody eye exercises and they all perform better. But the reality is you have to identify those athletes who have the problem and then do the 6 analytical tests to see where the problem is. And now, having established the scientific protocol, we can say with some degree of confidence that if you fix that problem, it may be 1 or 2 or 3 of these elements that's at fault, then you have a chance of improving their sporting or occupational performance. So in conclusion, what we find is that any fogging equivalent to uncorrected myopia or astigmatism, or even a dry eye, which is causing problems with the tear film, can be attributed to a degradation of sporting performance. And this cannot be understood, the cause of this cannot be understood without reference to eye dominance. And the beauty, I think, and this is what I think the main encouraging conclusion is, that the problem is treatable with specs or contact lenses, and gives rise to the principles of occupational visual performance. And there's one more slide I just want to refer to. And that's what bearings this might have on the future, on future research in the understanding of optometry. Well, when someone does air shots in any sport, or they're mistiming their cue in golf, what is this? This is generally a problem of not aiming, or aiming where they think the ball or the object is, and it's not where they think it is. Now, this is a description of dyspraxia. What dyspraxia is, when you see it obviously in children, is the inability to judge where an object is. So they become very clumsy. They have to walk slowly to avoid objects. They're constantly tripping over things because they don't know where they are. In sport, it's a much finer, subtle distinction, but the problem is the same. It's sporting, it's dyspraxia. Now, it follows from that when it comes to reading, it's likely that the problem is exactly the same, because if you have difficulty changing your attention from one letter to another, one at a time, if the aiming eye isn't pointing in the right direction, you won't be able to see the letter that you're looking at. Now, you might say that dyslexia is simply distance dyspraxia. And in fact, what we find in practice is that almost inevitably people with dyspraxia are also dyslexic. But not necessarily the other way, because dyslexia is a near vision problem. And sometimes that's mainly due to the need to converge eyes on the subject, which isn't the same as in sport. Often that's more distance, and that problem of converging doesn't arise. So dyslexia is a manifestation of distance dyspraxia. And it's likely that dyspraxia always coexists with dyslexia, but not the other way around. And what I hope to do is discuss that in more detail in the presentation, which I think is tomorrow, on reading speed, where some of this information has come from. So I think that's covered more or less what I want to say. And unless anybody has any questions, I look forward to seeing you at the next presentation, which is, I think, later this evening on colour vision. Thanks very much.
Thank you, Dr. Jerian Griffith, for your presentation. So, do we have any questions?
I was just going to say that if you are interested, you can go to the publication. If you tap in the title of this presentation, it will bring up the publication which on which this presentation is based. So that'll save people having to think of questions on the hoof.
So that was a wonderful presentation. I was just wondering, have you ever given it when they have when you're mixing up the dominant eye and you're swapping it and making them see with the non-dominant eye? Have they, like how we give for children for training, have you given them time and retested after a few months to see if their performance is getting better? This could probably give you an idea about neuroplasticity, and it will also let you know, give you an idea about how the person adapts as different sports people, how they adapt. And I'm sure that these people will be able to adapt because they'll be losing their depth. Whereas I'm sure the shooters and other sports might probably pick it up. So it might probably expand the scope of the
Yes, tell me if I've understood the question. That can you teach the other eye to become the dominant eye, in a sense, if there's an accident or a problem with the dominant eye?
Yeah, so if they like how we have ambidextrous, we can train our left hand to shave. We can train when you do phaco's, we do with both hands. So I'm sure will the eye be able to, when you're going to get a non-dominant eye, will that be able to even acquire some extra additional capabilities with the dominant eye with time?
Yes, now the brain is wonderful. The brain can readapt if the situation demands it. But the problem is it's never as good as the way nature intended, because you have to start second guessing the ability to judge depth, judge aim. Athletes do it all the time. Golfers who are left eye dominant and right-handed have to learn to hit the ball in a different place to if they're right eye and right-handed. So if they're left eye and right-handed, it's different. You have to second guess, and it's never as good as if you're just doing what the brain tells you to do. And the reason for that is because the only way in which we can judge where we are in space and deal with all the variability in life is by believing what the brain tells us. Now, if the brain is telling us untruths, if it's saying an object is there and it's there, then you can't function. Now, if you lost the eye, then yes, it will readapt to a degree, but it's never as good as the original. Now there's a colleague of mine who started life as a dentist, who had an amblyopic eye. His dominant eye was just 6/9, so not very amblyopic. And he did the first 3 years of his dental course fine, but then when it came to practical, he couldn't judge depth to the fine extent that dentists need to do that in order to drill a filling. So he literally gave it up and came and did optometry. So the question is, although the brain can adapt, it can do all sorts of wonderful things. It can learn to see with the left eye, can learn to see with one eye. It's never as good as with the gift that God gave us.
Yeah, thank you.
In my opinion.
Nice presentation, well done.
Thank you, thank you.
So any other questions we have? I guess there are no questions. So thank you, Dr. Griffith. So we'll be waiting for your next presentation then.
Oh, okay, thank you very much. Thank you.
Thank you. So let's move on to our next presentation. So we have a next presentation by Dr. Ioannis Aslandis from Emetropia Eye Clinic or Optotech Limited, Greece.
Hello, hi. Hi, I'm not Dr. Athanidis. My name is Vasilis Andreadakis. I'm a co-presenter of this presentation. Unfortunately, I'm really sorry about it. Dr. Athanidis had to go urgently in the surgery room. So I'm gonna present the whole presentation myself and go through all of the topics. I myself am not a doctor, as most of you are. I'm an engineer, a communication engineer, and an eye tracking expert. So when Dr. Athanidis had this idea to assemble a team to look further in reading, in dyslexia, and in eye tracking, try to take people with different backgrounds, like myself and like Dr. Ioannis Bernakis, who is a physicist mathematician. Dr. Athanidis is also a surgeon ophthalmologist, and we also have in our team speech pathologist. So we did try in this research project that I'm going to present to you, we did try to find a way to cover all the aspects of reading, and especially with regards to dyslexia. So to start my presentation, we tried to evaluate the silent reading using eye tracking technology in elementary students in the Greek languages. I would like to start by saying that reading is the foundation. Reading is the foundation of acquired knowledge. We cannot acquire knowledge unless we try to read something. So it's actually a universal passport to equal opportunity and, of course, a better quality of life. But this becomes a problem when someone has dyslexia. Dyslexia is the most prominent reading difficulty and affects billions of people worldwide. It's estimated that its prevalence is about 10 to 20% of the global population. And to be dyslexic, in simple words, means that I cannot read and I cannot write properly, although I have normal vision, normal hearing, adequate IQ, and I have attended school. So although I have all these things, I still cannot read and write properly. The problem with dyslexia screening and diagnosis at some point is that there is a lack of consensus in the definition. So you might be dyslexic in one country and not be dyslexic in another. Or you might even be dyslexic in one state and not be dyslexic in another. It's all about definition, which is unfortunately it's not unanimous. The lack of objective and fast tools also is a big problem for dyslexia screening. And the wide use of subjective approaches results in many children to be misdiagnosed, which is very bad, or not diagnosed at all. So to have a label of being lazy or anything else, instead of just being diagnosed as dyslexic. So there is a need out there, the global need for objective and fast screening tools to be able to screen large population very fast and take care of those who actually need help. In our research, we had two main objectives: to examine how eye tracking technology can be applied in young students in Greek elementary schools, and second, and most important, how this technology can distinguish a group of dyslexic students from a group of typical students while they read the text, but this time read it silently. The normal way of reading is to read silent, but we didn't have any means to measure silent reading until now that we have eye tracking technology. We only could measure loud reading because somebody could hear us talk and make some remarks from what we say. But now we can actually evaluate silent reading. So a few things, a few basics about eye tracking. Eye tracking is a technology that makes possible to know where a person is looking without him telling you. That's the great mystery. that you can see from actually his eyes, and can give us a real-time depiction of what we see or read. We care about reading at this presentation, so we'll focus on that. It is clear, of course, that dyslexia is not caused by oculomotor deficit. We don't have an eye problem which causes dyslexia. It's the other way around. Dyslexia is there, and we can see it happening through our eyes. So the depiction of what we call reading path can come by capturing our movements, capturing a subject's eye movements, and then evaluate them while he's reading silently. So in this photo right here, you can see blue dots and orange lines. The fixations are the blue dots, which is the points where our eyes stop for a few milliseconds, so our brain can assimilate the information. The longer the time of the assimilation, the time of acquiring the information, the bigger the circle. So when you see that the dot is a circle, is bigger, that means that our eyes stayed a lot longer in this spot because we didn't acquire knowledge very fast. The orange lines are called the saccadic movements, which are quick, fast movements of our eyes moving from one fixation point to another. During this movement, our brain, our eyes are blind. We cannot actually assimilate information, but they are very important because they can tell us things about how fluent readers we are. So if we stride on a text, if we stride on a sentence, meaning that we do big saccadic movements, mean that you have fluency. We can read faster. But in comparison, for example, with the dyslexia student, his steps on the text are very small, and you will see it in these photos here. So we have what we call reading path, and we can evaluate reading patterns. So you can see that the dyslexic pattern is the one that has too many blue dots, too many fixations. The fixations are not just dots, but they are circles, so too much time to assimilate the information, and too short saccade movements. So that means that this our reader, this dyslexic reader, is struggling in comparison with a dyslexic reader that has only a few fixations, and they're quite small. You can barely see them, and it can have higher and longer saccadic movements. To measure these eye movements, to record these eye movements, we used a 4C eye tracker from Tobii manufacturing. It's a Swedish company. The specifications of this eye tracker is it was a low budget and with 90 Hz refresh rate. The good thing about this eye tracker is that it is low budget in comparison with others, are quite expensive, cost thousands of euros, but this is affordable, and now this is how we can actually use the eye tracking technology much more wider in our research projects. And to run our experiments, we also used a very powerful computer and with a processor Intel i7. We asked our participants to read texts silently in the Greek language. We did that in Greece, while their eye movements were recorded. We didn't pick the text at random. We asked from a special education teacher to write this text, especially for this project, because we wanted this to be age appropriate, so we can assess all the students with the same texts. The specification were that, of course, they were written in the Greek language, as I mentioned before. We used a font named Courier New, which is a monospaced font with font size 30. We used black letters on gray background, and we divided the texts in lines. So approximately we had 6 lines per page. Our participants in this research were 71. We assessed 71 Greek native students, year 4 and year 3 of elementary school. Their group span was about 8 to 10. That's increased the year 4, the year 3 and year 4. We have one group which consisted of 32 children diagnosed with dyslexia by an official governmental agency. And we had the other group, the typical group, the normal readers group, which consisted of 39 children that didn't have any reading difficulty at all. Before I present you our results, I would like to talk to you about our accuracy and our reliability in the classification model. In order to measure the accuracy and the ability to be reliable in a model, you can use a metric called ROC, Receiver Operating Characteristics, which is a measure. It is a metric to measure the performance of a classification model. It's in simple words, it depicts how good, how well your model separates these two groups. Our groups were typical readers groups and a dyslexic readers group. So we combined year 3 and year 4 students for each parameter, and we did get the results I'm presented to you in 4 parameters. As you can see, we had very, very good numbers in the ROC curves. So you only need about 0.7 for a test to be classified as fair, and 0.8 as good. And we had more than 90 in the classification model. That means that our tool tries and successfully separates these two groups from one another. And this is the first slide with the results. Here you can see the first set of parameters, which they were called non-word specific parameters, and we call them like that because they are not directly related to the text that it was given to the participants to read. So we have reading speed, we have fixation number, you know, how many blue dots, as we saw in this picture. Mean fixation duration, which is the average duration of all fixations during reading. Mean saccade length, and 20% quartile, which is the 21st shorter saccadic movements. In this depiction, you can see that the typical students are with the blue, and the dyslexics are with the magenta. So you can clearly see how well separated, even with error bar of 1 standard deviation, how well separated are these two populations to one another. The first column is the students of year 3, grade 3. The second column is year 4 students, and the third column is year 3 and year 4 combined. We can combine these two years together, the school years together, because they have similar, not identical, but similar expertise on reading. The second slide is the other set of parameters called word-specific parameters, are the parameters that we can get from eye tracking technology that are actually directly related with the text we're reading. So we have not fixated words, meaning that there are a few words in the text that you didn't fixate at all. It's not that you didn't see them, but you didn't fixate. So you might have used your peripheral vision in order to read them, because you eventually read them all. Or you can use your guessing ability as a fluent reader. So you can, as an example, I can give you, you can understand what is the article is before a noun. So you can guess it because you're a fluent reader and you know how it is. But this is a characteristic of typical, if you are typical. If you're not, then it is still a problem for a dyslexic reader. Even this article is a problem. Multiple fixated words are the words that have more than a single fixation. So that means that you read it, you go forward in the text, and then you go back and reread it again. The gaze duration in general, in a group of 6 and 7 character words, which is also very indicative in separating these two populations. The gaze duration of words that have more than 8 characters, 8 or more characters, and of course the backorder fixation, which is again a very important parameter in eye tracking, because you read something, you move forward, and you're not able to grasp the meaning And so you go back, and sometimes you just read a word or a phrase or a full sentence in order for you to understand. So it's very typical for dyslexic students. So in conclusion, we have many eye training parameters such as fixation duration, saccade length, average fixation duration, the number of fixations that can provide information that was not accessible to specialists until now. Because until now, we could only assess a student just by hearing him speak out loud or with a standard printed text. But we are missing quite a few of information, as I showed you before. So we had more and new and fresh information that we can now assess and separate if and evaluate if someone needs our help or not. Eye tracking technology can separate effectively a dyslexic from a non-dyslexic student based on a series of eye tracking parameters, which we obtained during silent reading. And most importantly, eye tracking can play a vital role in creating tools that are amendable in large screening population, that are amendable even as a universal tools, because you don't need to be specific on how the text is preserved anymore, but you only need to capture the eye movements of the person that you are assessing. So it can be amendable in large screening population very fast, very accurately, and can separate only those who actually need your help. So no more misdiagnosis, or most importantly, no diagnosis at all. And this is very important. It is imperative, as we see here, to improve the current methods for screening and diagnosing. And we can use them objectively, quickly, and quantifiable to produce results for students that are not in the typical realm of reading. And we can do it fast. That's all I have to say. Thank you very much. Thank you very much for your time. And I'd like to answer a question if you have any questions about our research.
Yes,
Thank you.
I have one, if I may.
Yes, please.
In your studies, did you identify any probably small group of subjects who had all the signs of dyslexic tracking problems, who, when you'd sit them aside, say, but I'm a great reader, I read very fast? Were there any subjects who fell into that category?
No, because we didn't pick them at random. Our subject groups were picked by an official governmental agency that identifies diagnosed students with dyslexia. So all the students that we used in our models, they were assessed multiple times and with multiple tests, so that we know that we can train our model to actually identify what dyslexia is. Because what you're describing is something that can make things more complicated, since we don't have a unanimous definition of dyslexia. So if we mix dyslexic students with poor readers, let's say, as they call it by New York, then it's going to be a very big problem for the model. So we didn't have in this research people that can be separated and not being typical but not be dyslexic at the same time, because of that, because they were well categorized by the government agencies.
Yeah. So they wouldn't even present, would they? That's why you didn't see any of this group. They wouldn't even have presented to you.
No, not in this sense. We have multiple sentences. We have noticed the effect that you were saying, but in these 71 people, we had only people that were dyslexic or people that were typical. We didn't have something in the middle or outliers.
Okay. Thank you. Thank you for that.
Do we have any other questions? Okay, I guess there are no questions. So thank you for your presentation,
Thank you very much
Mr.
for your time. Thank you
Vasilis.
very much all.
Yeah,
Thank you.
thank you. Have a great day ahead.
You
So
too.
yeah, now let's move on to our next presentation by Dr. Hessa Al-Matar, optometrist from Saudi Arabia. So just your screen is visible and it's perfect.
Okay, can you hear me, guys?
Yeah, we can hear you.
Okay,
Mhm.
so just give me a second, please. Okay, still not there. Okay, greetings, everyone. First of all, I would like to thank the organizational committee for all their efforts and giving me this opportunity. And it's my pleasure to present my research in this webinar. So, okay, before beginning with my research, first of all, as you all know, that overweight and obesity are world major public health problems and has been increased dramatically throughout the world, especially in Kingdom of Saudi Arabia. According to World A+ data, Saudi Arabia has been ranked as the 15th most obese country in the world, with an overall obesity rate of 33.7%, which is a huge percentage. And as most of you also know, that obesity, defined as an excessive fat cell accumulation, it is considered and measured by the body mass index, which is calculated as the individual weight divided by the square root of an individual height. And we could say that someone is in overweight and going through obesity when the body mass index exceeds 25 kilograms per meter square. And according to one of the studies who did a secondary analysis to published data in order to give an estimate about the future projection of adult obesity in Saudi Arabia from the year of 1992 till the year 2022, have found that an obesity going to increase from 12% up to 41% in men, and from 21% to 78% in women, which is a huge percentage, especially among females. So, as it is well assured by studies that obesity and overweight affect the vascular system in general. And since the choroid is a vascular structure, this causes a question to pop in our mind, which is whether the choroidal morphology is going to change as a result of an increased body mass index or not. Before going through our study, I would like to introduce some information about the choroid. The choroid is the most vascular tissue of the body. Actually, also located between the retina and the sclera, and it maintains the health of the eye by supplying the retina with oxygen. Going through our study, our purpose is to examine the possible changes of the choroid by measuring the choroidal thickness in different body mass index groups of healthy Saudi females. To our knowledge, this is the first study conducted in Saudi Arabia among females. So we did a cross-sectional study of 140 subjects, 140 eyes, and their ages between 18 and 40 years old, and they are females. We classified the subjects into 4 groups based upon their body mass index, and according to WHO international classification, into 4 groups: underweight group, normal weight group, overweight group, and obese type 1 group. So we included the subjects when their refractive errors are between +2 and -2 diopters, and their visual acuities are 6/6 or better. They don't have any ocular or systemic diseases, and their intraocular pressure is less than 21 millimeter mercuries, and their body mass index is less than 35 kilograms per meter square. All the subjects underwent a pre-examinations, including non-cycloplegic refraction, axial length measurement using an IOL master, visual acuity using a standard Snellen chart, and intraocular pressure using an airpuff tonometer, and the body mass index was calculated after measuring each subject's height and weight. For our main measurement, which is the choroidal thickness, first the image was captured using an optical coherence tomography, And then by using the built-in clipper of the machine, we measured the choroidal thickness as the vertical distance from the outer portion of the retinal pigmented epithelium till the inner portion of the choroid in 5 different areas: a subfoveal area, nasal and temporal to the fovea by 1000 microns, and nasal and temporal to the fovea by 2000 microns. And then our results were statistically analyzed using one-way analysis of variance, and the Pearson's correlation was used to examine the relationship among the measured variables, and a p-value of less than 0.05 was considered statistically significant. So our findings are summarized in this table. As you can see here, here are the 4 groups, and these are the 5 different areas of the choroid. Our results shows statistically significant differences in the thicknesses of the choroid among all the 4 groups in all the 5 different areas with AP values of less than 0.05. This figure actually shows it in a simplified way. As you can see here, when the body mass index starts to increase, the choroidal thickness starts to decrease, which give a rise to a negative correlation between the choroidal thickness and the body mass index. So overweight and obese type 1 subjects have a thinner choroidal thickness compared to underweight and normal weight groups. Our findings match with other previous studies who also found a negative correlation between the body mass index and the choroidal thickness. And how does this occur? Actually, according to one of the studies, they found that there is an increase in the endothelin and angiotensin 2, which are vasoconstrictors. This increasing in these 2 factors is associated with an increased body mass index. Also, another study found that in obese subjects have a decreased level of nitric oxide. So we hypothesized that both of these factors, which are an increase in the vasoconstrictors and decrease in the vasodilators, are the reason of the alteration of choroidal morphology, which may causes a reduction of ocular blood flow and oxidative stress, thus increases the risk of the incidence and progression of ocular diseases like diabetic retinopathy and glaucoma. So in a conclusion, our study contributes to better understanding of the body mass index as a factor which may influence choroidal morphology. So in the future, anyone would make a study about the choroidal thickness should consider the body mass index as a factor which may influence on the choroid. So we would recommend an annual eye examination for the obese individuals, thus reduces the risk of developing vascular ocular diseases and increasing the awareness among not only the Saudi population, the whole world. We should increase the awareness about obesity and increase body mass index, and to maintain normal weight and to change their lifestyle, thus reduces the risk of many not only health diseases, but also in ocular diseases. That's it. Here are the references. Thank you so much. Do you have any questions?
Thank you for your presentation, Dr. Hissa. So yeah, do we have any questions? Okay, I guess there are no questions. So yeah, thank you. Thanks a lot for your time and your presentation.
Thank you so much.
Yeah. So let's move on to our next presentation, that is from Dr. Fernando from Palomar Optometric Center, Spain. So we have a video presentation of this. So I'll be playing the video of this presentation. Please do confirm me if you will be able to listen to the audio so that we'll just see. Please confirm me if you can listen, sorry, if you can see my screen, and I'll just be playing the audio now. Just give me a confirmation if you all can listen to it.
Please let me know if the audio is audible to all so that I can continue with this. Okay, so are you able to listen to the audio? Not yet, okay. Please confirm me if you can listen to the presentation. Is it audible to you all? No sound. Okay, just give me a second. I'll just check. Could you please confirm me if you are able to listen to the audio now? Oh.
Unmuted. I can see the screen, but I can't hear anything.
Okay, just give me some time. I'm just checking this out.
The injury is always retrochiasmatical on the encephal left, remembering that the two optical nerves cross.
Is that fine now? Like, could you
Still
hear it?
No, not at all.
Still no audio.
Oh. Just give me some time. I'll just check with the video, but in the meantime, maybe we can just proceed with the next presentation just to not waste time. So I just want to know if Dr. Sibyl is ready.
Yes, I am.
Oh yeah, that's great. So
I'm waiting for the
Yes, Doctor.
camera.
So, yeah, now let's just have a next presentation by Dr. Sybil K. Pauls from Saarland University, Germany.
So thank you very much for your kind introduction, and I'm happy that I'm early in this Congress to fill this gap. As you requested, a little bit of background from my person. I'm a biologist and chemist, but I did my PhD in ophthalmology. Some strange CV, but it's there. Right now, I'm working as an international science correspondent on one side and an associated senior research fellow at the Institute of Experimental Ophthalmology of Saarland University in Germany, for which I'm here presenting today. And additional to that, I have more than 30 years of experience in the ophthalmic industry, in the ophthalmic medical device industry, and in the national and international medical device law. So I try, oh yes, arranged for that too. So again, thanks a lot for your interest in this topic. I'm very proud and very happy that you accepted this topic, as it's really important not only for ophthalmosurgeons, but also for all the optical engineers, the oops, this was not on purpose. Also for the optical engineers who do the pre-examination before cataract surgery and who usually also do the IOL calculation for the IOL to be implanted. And that, I don't know what I did wrong. I will do it like this. I think then it's not shifting on its own. So my lecture goes out to all those who are dealing with IOL calculation, and I would like to introduce you to the most modern, most updated database of IOL specifications, as well as optimized IOL constants, which is available in the internet. It's called, as you can see, IOLCon. That's 9. Sorry. So everything started about 20 years ago. Optical biometry, as you know, changed ophthalmology completely. It was 20 years ago when the first optical biometer, the size IOL master, showed up on the ophthalmic landscape. And combined with this biometer, Wolfgang Heiges, a professor from Würzburg University, also Germany, set up a database called ULIP, where he stored all the optimized constants for this optical biometer. And this was unique for the world. It was the very first database of such data used by all ophthalmologists all over the world. ULIP really set a milestone in providing those optimized IOL constants for cataract surgery. But after 20 years, at least something has changed in ophthalmology, and ULIP does not meet modern requirements anymore. To meet those modern standards, another professor from Germany, Professor Achim Langenbucher from Saarland University in Homburg an der Saar in Germany, developed Heige's ideas further to provide a most modern database of IOL constants, optimized constants, and all the specifications around the IOLs, like material specifications, optic specifications, haptic designs, diopter available, everything. And so finally, he was working on that many years, and finally in 2017, he launched this database officially, and this is IOLCon, and I would like to introduce you to this database today in more detail. So that's what I mentioned before. ULIP was there, and it was really a milestone for ophthalmic surgery. It was really outstanding. The downsides of ULIP are, on one hand, ULIP focused only on the ZEISS IOL master, only on one biometer, as it was the first one available on the world. ULIP was like a data sheet. It offered very limited filter functions, if any. As well, it did not offer an open interface to other biometers except to the IOL ZEISS, to the ZEISS IOL master. This was the only biometer which had a direct download option to the data ULIP stored. In addition, and this is quite sad, since 2016, there has not been any update of ULIP anymore. And very, very sadly, some years ago, Professor Heiges passed away. There will be no update of ULIP to be expected. But there is a contract in place between Professor Langenbucher and Professor Heiges that Professor Langenbucher is allowed to show the data Heiges collected in his database. So nothing got lost, even if ULIP is not existing or will not exist anymore. So you get all the data. If you're used to the data in ULIP, you can see them or you will find them in IOLCon as well. So Langenbucher's ideas of such a modern database is everything what we discussed before. He wanted to establish something modern, open to all IOL manufacturers, biometer manufacturers, open to all ophthalmosurgeons, and he wanted a surface which is really easy to use, which is really conveniently usable. And to my perspective, with IOLCon, such a modern biometric database is in place now. Thank you. So IOLCon is completely independent of specific devices, manufacturers, or surgeons. And this is very perfect for ophthalmic surgery. So the launch, it was mentioned before, it was officially launched in 2017. It's modern, it's independent, and the data in IOLCon is provided by two user groups. On one hand, the IOL manufacturers or the distributors provide this data. They have an account, they have to register and have a special account where they can upload their data for their respective IOLs. So this is up to date always, because all the manufacturers are interested to show updated data in IOLCon. So there is no delay in updates of this data. And on the other hand, the ophthalmic surgeons can have access, can send their data, their post-surgical refractive data to IOLCon to ask, or they will, if they send their data to IOLCon, they will receive their own personalized, optimized constants. For this specific surgeon, he gets his individual optimized constants, and most of all, this is for free for the surgeon. And as mentioned before, by today, most of the data in ULIP, from ULIP has been transferred to IOLCon. So there's only one database you need if you are looking for constant specifications or optimized constants. So as mentioned before, it's free of charge for ophthalmic surgeons. To me, it's an essential tool for ophthalmology, most of all for those people who deal with IOL power calculation. It's easy to use, and you can see a screenshot. We can maybe later just look at the website and play around with the website, what it offers. And there are download options, and as well you can print the data very conveniently. Sorry for that, the alarm clock. And there is only one single sheet of paper needed, and all the information is shown on this single sheet of paper for this specific IOL you choose and you want to know about more. So I think this is very helpful, very easy to use. Just have a look at the various search options and all the various data you can see and you can retrieve in IOLCon. Oops. It provides an up-to-date overview. That's what I told. And you can check for important specifications, for all specifications for I think that's the next slide I want to show you. You can check out for specific manufacturers, for specific IOL materials, for haptic geometry, for in general geometry, bifocal, multifocal, 8 of IOLs, whether IOL should be placed in the sulcus or in the capsular bag, or the ethnicities can be checked, can be selected as well. What I would recommend to you, just go to the website and just play around with all these options you have, and then just push the button, download the lenses, and you will see all those lenses you selected. And this is very, very helpful to me, I think. So a little bit more detailed information about the quality or about the optimization of this IOL constants at IOL constants at IOLCon. When you have a look at the website, on the right part of the website, you see it's mentioned there, optimized constants by us, by IOLCon. And there you can see numbers, and you find a color coding, red, green, and yellow. For those lenses, IOLCon already has optimized constants available. And it's like in traffic, it's a traffic light system. Green means very well, more than 500 clinical results are the basis of this optimization of the constant. Yellow is something in between. It's about 100 to 500 clinical data behind this constant, and red is okay, less than 100 data. And this is very easy to understand. As well, you will see on the right part of the screen additional information about the refractive power of toric IOLs. You know, you have the, most probably you know, you have the option to show your refractive properties of that lens either as refractive power as a sphere or the refractive power as a spherical equivalent if you sell a toric IOL. So this is mentioned there as well, because some manufacturers do this way and the others use the other way. It's important to know, if you are going to calculate the toric IOL, which option did the manufacturer choose for his for indexing his toricity of the lens. This is really, to me, one of the most lovely, one of the most loveliest toys in here. It's not a toy, in fact, it's really a really good feature. Before we saw those optimizations, but if you want to dig deeper in the quality of the optimization, just use this mouse over, just put the cursor of the mouse over one of those squares, and immediately another window will pop up and show you the basis of this optimization. So how many clinical results have been used and what was the difference. So this is really science, and if you're interested in this deep knowledge, this is really a lovely feature. So the benefits for the ophthalmic surgeons, I think they are quite clear. Registered users or colleagues who are dealing with refractive results and IOL power calculations, they will receive their own optimized constant, as mentioned before. As well, you can, right now, if you look at the website and if you are not registered, you will see also optimized constants based on global data, based on community data. And either use the QR code I'm showing this presentation or use the website, which you can see down here, to register or to go to the webpage of IOLCon. So regarding the registration process, it's not rocket science. It's really easy. It's absolutely easy. This is the main page. If you enter iolcon.org, then you will see this page, and just go down here to the contact button and push this button. And if you do so, you will see this page. And then it's really easy. Just put in your name, your email address, click the button that you would like to register as a new user. If you need to send a message, do so. If not, it's not a problem. Just send the main data to IOLCon and then push the button, send form. And then IOLCon receives your interest and they will come back to you as soon as possible with your registration information and login details. After that, after you have been if you are a registered user, you have two options to upload your post-surgical data. Either you would like to use an Excel spreadsheet, then you can download this here. Or if you prefer XML, then you can download this spreadsheet with this button. And that's all you need to fill out then the spreadsheet and send it back to Professor Langenbucher, and he will come back with your own optimized results, optimized constants. So slowly to conclude, IOLCon is really growing steadily. By now, we have about almost 500 IOL models in the database from 30 manufacturers with over 22,000 clinical results for 123 IOL models. And another thing which we are really proud of is that biometer manufacturers are including the direct download option into their biometer. For example, the Anterion from Heidelberg Engineering or the OR2000 from Tomy, and the latest software update also from the IOL Master 700 has a direct contact to the IOLCon website to just easily download the constants which are stored in IOLCon. So really, in conclusion, IOLCon offers much, much more than only a static table, than only a static Excel sheet. It's globally available, it's most modern, most updated, and it's really a tool of ophthalmo surgeons. All the people who are dealing with cataract surgery and IOL power calculation will need this tool. It's quite new, and that's why I'm presenting about it, and I'm really happy that you're listening to me. As my last comment would be, by implementing IOLCon, a biometric database is already today available, which will also meet the future demands of an ongoing developing ophthalmosurgery. Right? Yeah, this. Thank you very much for listening to me. I'm happy if you have questions or if you would like to have a look at the website, we can do that as well.
Sure,
So,
that's possible. Yeah, you can
good.
open the website too. Yeah.
Oh, great. That's what I showed you before on my presentation. You have, you can look for all lenses. You can over here, you can select whatever manufacturer, which material, preloaded, yes or no, diameter, optic concept, optic design, aberration, spherical, yes, no, correcting.
Yeah, but the website is actually not visible right now. Only your
Oh,
presentation is being visible. Yeah. I guess you have selected the application and not the screen while sharing your screen with us. Maybe.
okay. What
Mhm.
what do I have to do? I'm sorry, I close my
Uh,
presentation and
yeah,
then,
please do close your presentation. We'll just see
yeah,
if that'll work.
bildschirm
Or
wird.
you can disconnect the screen and again reconnect once again. Yeah, now it's visible.
Good. Ah, I saw something purple around the screen and I thought that is not, sounds not good.
Oh yeah. Hmm.
So this is the introduction page where you are, where you arrive when you just go to the website or screen the QR code. This is what I showed you before. No, I showed you the other one. If you go for this page, then you can see all, really all of those IOLs of all the manufacturers. You can scroll down and see all of them. You see many, 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 many. It's really all the main IOL manufacturers have put their IOLs into this database. Oh, no, I did something wrong. I just wanted to try. So, nein, Download wollen wir nicht. So what I mentioned before, here you see on this is always what I call the right-hand side. This is the page where, or the side of the IOLCon database where the manufacturer provides his data, or if he transferred from ULIP. And there are three, and it's another mouse over if you go to the square and you see this 5.89 adopted from ULIP. And even if results are behind the ULIP database, then the clinical results are mentioned there as well. And everything is mentioned. Oops. You don't have to remember that. That's what I showed you on my presentation as well. Everything is mentioned in the footnotes as well. You can read if you're not sure what the 3 or the 1 means, just go down there and check. And the other thing is on the right-hand side, you find the optimized constants by IOLCon. And you see what I told you before, the yellow, For example, here, the yellow square, it shows you the optimized constant. And with the mouse over, you see the data behind, which is the surgical data, the post-surgical data, which is behind this calculation. And this is really deep science and really open. You can see what has been done. What else can we do? Go back menu. This is my preferred page when I want to look for several properties, anyway, for a manufacturer or for the material. If it's preloaded, should it be preloaded or should it be not preloaded? Optical diameter, optic concept, optic design, sphere, as I said that before. And down here you will find all the available powers and the addition. And in case it's a toric IOL, we will see the toricity down here. Let's check for maybe this one. And yeah. And now we see all the lenses Johnson & Johnson is providing. Here, for example, we have a green square. So there are more than 500 data behind this calculation. And you can see the details when you're using the mouse cursor. And just wanted to look for a toric IOL to show us. This is not in general. I think I told you what I meant. Over here, you find the original constants from the manufacturer or from ULIP. And over here, you find the constants, the modern ones, by IOLCon. So far from my side, again, the question for question.
So yeah, do we have any questions?
I just wanted to ask, is the instrument that measures the chamber depth still ultrasound?
No, I pray that it's not ultrasound, because with modern optical biometers, you can diagnose about 98% of the patients. Only if they have a really dense cataract or scars on the cornea, then you still need ultrasound. But usually in industrialized countries, you should not be ultrasound should not be used in the normal cases, the general cases, because the most modern swept source OCTs, for example, get through any dense, not really dense, but somehow dense cornea and lens. As mentioned, 89% of eyes in our countries can be measured by modern optical biometry, not ultrasound anymore.
Is this technique applicable to autorefractors?
Good question. No, there's not. How do you want to combine it? I don't understand that.
Well, you know, in optometry, we can get an estimate of the refraction using an autorefractor.
Yeah.
I'm just wondering if that machine is similar to the biometers that you use in cataract surgery.
What you can do with the modern biometers, you measure the length and the length of the distances, and you can calculate the eye length. And by this, with the corneal radius and everything in sum, you can calculate the refractive power of the eye and the refractive power of the lens, which is needed to be implanted. And you can measure the distances in the eye. Was this the answer?
Okay. Yeah, that I understand what you're saying. Yes. The other thing I'm interested in is the material itself of the implant. Is any consideration to the UV absorption of this lens? Is that taken into account these days?
Really all. Also, the old lenses had an UV filter in it. really also the old silicone lenses had that kind of filter in it. Modern lenses, there's a discussion if you put a yellow filter or a blue filter or a violet filter into the lens to absorb blue light or violet light to have not this harmful effect of this high energy light on the retina. So some of the manufacturers provide lenses only with UV filter, like always, and some other companies provide IOLs with blue filter, which are completely blue blocking the blue light, which is under discussion if this is blue light is needed for several things, for circadian rhythm, for waking and sleeping, and that's why some other companies use the violet blocking option just to cut off the very harmful violet light, but let the blue light in. That's a compromise. That's the recent status.
Is there any progress being made on when the lens capsule is touched by the implant, it can cause capsular opacification? Is that still a risk with all the materials?
So far I understand PCO, this posterior capsular opacification, it's based on the bad cleaning of the capsular bag. If you are in a rush and not clean the capsular bag very good and implant the lens, then the remaining cells start to grow again, and this is PCO. It's really a measure just polishing the capsular bag very nicely and cleaning it up very nicely. This is one thing. Then PCO is really not an issue. And the other thing is the design of the edge of the IOL. If it's a round edge, then cells easily can move around the edge. And so a lot of manufacturers use IOLs which have a square edge pressing into the capsular bag. And then the cells cannot so easily migrate around the corner, around the edge of the lens. This is highly philosophical.
It is. And are there any problems stabilizing a toric implant?
It's always a big discussion with all toric IOLs, how they behave if they stay there where they are put or if they rotate in the eye. And there are many ideas, or a few ideas. Latest ideas showed up that the haptics, the last piece of the haptic is not polished, but it's really like a rough. It's a rough. It will have a rough surface, which is not so easy, which not easy tends to rotate.
Yeah.
So if it's smooth, then it might easily rotate, because also the capsular bag can be like this or like that. The IOL is usually always 13 millimeters, the diameter, and sometimes it might be an issue of size.
Thank you. We all take this for granted, don't we?
Yeah.
It's wonderful how much work has been done in this field now.
I'm so happy and proud that I live now. If I've compared with all the things, I admire Harold Ridley for his invention, but he had to undergo so many fights with his peers and discussions, and his first experiments were really not successful. And I'm so happy and proud that he was, let's say, stubborn and stayed to his science and to his kind of ideas of preparing an IOL. That we are living in an age, cataract is not harmful anymore. You go to the surgery, 10 minutes later, you turn from blind to see again. This is the beauty of our times, and the results of Harold Ridley and all the industry who is working on improving all those implants.
Yeah, brilliant.
Anything else?
No, that's me done.
Thank you so much. It was really a lovely discussion with you. I enjoyed that.
Thank you.
You're very welcome. Anyone else?
Yeah. Any other questions from any other person? I guess there are no questions. So yeah, thanks a lot for your presentation and your information. That was really informative.
Thank you very much, and thank you very much for having me and inviting me. I'm very happy and proud to be here. Thanks a lot, and have a wonderful Congress.
Thank you. Thank you.
Very welcome.
So let's move on to our video presentation. So where you have left it. So just give me a second.
Oh, next try. Mm.
The voice is not audible. Let me just check. The video is the audio is actually not audible, and we have been trying to play it, but it was not successful. So maybe as of now, I think I'll have to skip that presentation for today, because I'll just have to check again with Dr. Fernando with the same, so that we'll just see if we can help you out by providing some other video or any other source. So maybe we can just go for a 20 minutes break and come back, so that we can just continue with our rest of the sessions. So I hope everyone is fine with this, or if you are interested, then we can just continue with the sessions without any break. So let me know if anyone of you are interested in just continuing. So with the majority, we'll just see, or we can just simply go for the break and come back.
I would prefer a short break if you don't mind.
Sure, then definitely then we can just come back again 20
A
minutes
few
later.
minutes.
Yeah, 20 minutes. So we'll just come back after 20 minutes to continue with the sessions. Thank
Perfect.
you.
Thank you very much.
Thank you.
Oh no, I forgot it in the kitchen, but I was picking up some coffee. You're on mute.
Were you happy with your presentation?
Really? I was so nervous because it's an auditorium where I never did a presentation before. I'm used to give presentation in front of ophthalmologists, but not mixed group. I was really nervous, and it's so important also for all those guys who deal with cataract surgery and IOL calculation. They have to know about this database.
Yes, yes.
But your
Yeah.
presentation was, do you have a publication which I can read? It was so interesting with the blinded, the dominant eye. I didn't realize that, and that it affects sports.
Well, it's the if you copy and paste the title of the presentation into Google search, it'll come up with it.
Good, good. Because I have to read that more intensively, because to me it was just amazing.
Ah, well, it is. When you see the presentation, it'll fill in the details, and it is amazing. I think in a way it could have a profound effect on optometry in the way that IOL lenses have had.
Yeah. Alexa aus. I set a timer that I don't be late for the next round of the meeting, and the timer was just waking me up. I had to shout at Alexa. But she understands in general, she understands only German.
Oh.
On my end, at least. So,
does she understand when you say in English then?
I never tried that. I should do that. It was set up as a German thing. Also from Amazon directly, everything was set up as German.
Yeah.
I could try that.
Well, I think it's astonishing. The voice recognition technology is unbelievable.
It's absolutely unbelievable. It's just, I got aware, beginning of the Corona crisis, a dear friend of mine in the US has an Alexa thing at home, and she forced me to buy another one that we can chat over this device. And I thought, okay, and now I really love it.
Oh, you can chat to each other.
Yeah.
Via Alexa.
Also the video, you see the room where you are. And now I have to show you somebody else who's waiting to be. She wants to sit on the. She wants always to sit on the desk, but she has only 3 legs and she cannot jump.
Oh.
I found her like that at the cat shelter. I don't know what happened. Most probably a car accident or something like that. But she's with me now for 10 years, and she trained me very well what she wants. And if she's sitting here, she wants on the table and wants to see the screen, what is happening there. She's looking at you and watching the screen. Sometimes her paws go out on the screen.
Oh. Is she happy? She's obviously happy. It
The rest
hasn't
of her,
traumatized her.
I think she does not realize that something is different with her. She's just a cat, and she's just, oops, Katze, noch mal reingrinsen. Nein, geht das? Oh no, she's, nein.
Oh.
She's just greeting me and saying thank you that I took her, put her up on the table.
Yes.
And later, when I'm busy with the presentation again, she falls asleep. That's also Corona life with a cat. So where's the rest of the group? Are we too early or are they too late?
Well, we're on time, I think. So.
I think so.
But officially, it doesn't start till 1:45.
Oh, okay.
So that's probably what the schedule they're working to is.
So okay, I thought she mentioned that the break will be 20 minutes.
She did say that, yeah.
Yeah, and that's why I put the Alexa alarm clock for 20 minutes. Where are you based, by the way? I'm just curious.
Well, in the UK.
Yeah.
In near Leicester. I don't know if you know that part of the country.
A little bit. I'm more familiar with the southern part.
Yeah. Well, if you think of Birmingham, which is about in the middle,
yeah.
We're just a little bit north and west of that.
Okay. I stayed several weeks in Edinburgh for an English course, and I had friends in London and in Guildford, which I visited fairly often. But the rest of the UK was not so far in my vision.
Well, you wouldn't unless you've been there. You can't orientate yourself, can you? It would be the same for me in Germany.
Would not be that bad.
Where are you speaking from?
I now live in next to Karlsruhe. Does it mean something to you? Or the nearest city you might know is Strasbourg. Yes. But about 70 kilometers northward of Strasbourg, on the German side, it's Karlsruhe.
Oh.
It's a city they have about 350,000 inhabitants. There's a university, and it's nicely located at the northern part of the Black Forest.
Sounds wonderful.
Not too bad. Could be worse, but for me especially, it's not the perfect area. I was born and I grew up next to Salzburg in Austria. And I miss snow and ice and winter so much, I can't tell you.
You don't get snow or cold weather then?
No, not at all. I think for the last 3 years we had not a single snowflake.
Oh.
It's boring. That's why I usually in December I go for a long weekend and visit friends in Iceland, and then I have enough ice and snowstorm and everything. But this winter with Corona and no trip to Iceland was possible.
Are you a skier?
I was when I was young. Now I quit. Still, the love for snow and for ice is still there. But I did tournament dancing for those ballroom dancing on tournament basis. I ruined a lot of my bones. And so I should go swimming or bicycle riding.
Yeah. You don't enjoy that. You just don't enjoy that.
I do, absolutely. No, bicycle riding is my car is faster.
You must have taken it very seriously to do that sort of effect on the skeleton, the dancing.
Yeah. We did also, it was about 7 or 8 years I did this in the competition, also with rock and roll, and also with Überwürfe. You're flying around in the air, and sometimes you just fall down and...
Oh, physically lifted then?
Yeah. It was great time. I don't want to miss it. But now I know why I need to go to the physiotherapist twice a week.
Does that help?
Yeah. And I think I will a hip replacement and knee replacement earlier than the average, but I try to postpone it as much as I can.
Yeah.
Wasn't it Winston Churchill with this saying, do sports or stay alive or stay healthy? There was something, treibe Sport oder bleibe gesund. I think that was Winston Churchill.
I think a lot of people say that. It probably was Winston to start with, but it's not obviously true. And I think there are a lot of athletes who suffer in that way.
But if you are in that age and you're doing the sports, everybody tells you that is harmful. You will ruin your ankles. You will ruin this, but you don't live it. Sports was my life. Sports was. I did school, and the university was just to. Yeah, I did it. But sports was more important to me. And I think that's for all who love to do sports.
I agree, and it's the joy, isn't it, of having that
Yeah.
physical ability.
Yeah, doing crazy things, and I really miss skiing. I went there, or I went sometimes. I went small hills up and down only a few times. Then I know that everything is hurting. But I just love that. But it's really the children's hill. Sometimes I use twice and then I'm done.
Oh,
Comes with age, I know. I knew before.
well, I'm in the same predicament because I did a lot of high jumping when I was younger. And I just had to have my right hip replaced because that's the takeoff leg. So I'm with you all the way.
I didn't tell you any new. Good. But it's two of a kind. But then you know how you love to do sports, and everybody's telling you it will not be good if you're getting older. And I didn't mind.
But I think apart from skeletal damage, you will be healthier because your heart will be good, and it sharpens the mind to think that way. So all you have to do is just change your focus slightly. And as you have done, you've concentrated on the academic side to keep the brain going and then manage the body. And I think you're left with a legacy of good health despite any minor joint problems.
Thank you very much for that. I keep my fingers crossed that this will be true.
Yeah.
What I did, but because we are now so far in this private discussion, I have a wheelchair, and there's a possibility to change it to have a hand bike. We have the wheelchair with a third bike in front, and you operate the wheelchair and the bike by the arms.
Oh.
Have you seen that before?
No, I haven't come across that.
That is quite. There's a clinic close by with people who can't use their legs in no way. And I saw them with this hand bike, and I just asked them if I would like to try it, and it was just fun. And it's you don't have the weight of your body, and it's not the boring thing of a normal bike. And you do it like a rowing machine. It's wonderful. I love it. And I have downstairs, and at least twice a week I'm out with this.
And is it the pain in your knees that stopped you walking properly, or just the knees?
The knees are most rotten. And by this machine, when you sit in the wheelchair, so your body weight is sitting in the wheelchair, the knees are free. You just use your arms, and a little bit of power is going to the legs, which is also good for the muscles and staying in shape, but it does not give the pain to the knees. This is, and I really enjoy it. It looks crazy if you see a normal person jumping into a wheelchair using this machine, but it's really fun.
Oh wow, I'd like to see that.
Do you have may I please ask you for sharing your email address, and I will send you videos. I just bought a new one with a motor, with a battery, an electric one. It's longer, and from a mechanical standpoint, it's more safe. You're closer to the ground, and you cannot swap over so easy. With the wheelchair, you're quite. If you're fast going into a curve, you fall over. With the new one, it's not possible because you're lower and the accident. It's larger, it's longer.
Yes.
I will send you the videos if you like to.
Yes, please. Have you got a pen there?
And the paper is below my cat. No, it cannot. I'm not allowed to disturb the cat. No, she's clearly the boss of the whole thing.
Yeah.
I'm ready.
Right. It's Geraint, and that's G-E-R.
Mhm.
A-I-N-T
Geraint.
at.
I can see it in your window, in the screen.
Oh yes, it's on there. It's on there. Yep, that's it.
And at spots. Vision. Cool. Just make a screenshot as well. Never know. I will send you the videos.
Thank you.
I hope everyone has come back, and I'm so sorry for interrupting you in between.
We had a lovely conversation.
Yeah,
We enjoyed
we
the
all
time.
had. Yeah. So, yeah. So, shall we continue with this session? I hope everyone has come back. So, yes. Now we have our next session from Dr. Garion Griffiths. Once again. So, yes, Doctor. Let me just make you the presenter. Yes. We can now click on the screen button to share the screen. Yeah, perfect.
Am I on?
Yes.
Right. So my second presentation is about color preference, and I've had an interest in this for a long time. And part of the reason is color is such a powerful communicator. And I think the transcendence of the visual system makes it arguably the finest discriminator at the highest level of sensory perception. Imagine the world without color, and imagine how much information we derive from the world because of the color within it. Now we know at the basic level, color filters are very important to eye protection. Because of the problems with the macula and too much UV radiation and so on. It's been known for a long time. But it's not obvious which color, whatever its physical properties, suit one individual more than another. And I've plenty of circumstantial evidence of patients who've gone on with a brown tint for years for all the right reasons. And then when they're offered a green or a gray tint, they think, that's wonderful. I never really liked that brown tint. So you can't really predict color preference from the physical properties of the tint. Now there is accumulating evidence about the importance of color in other aspects. For instance, Olive Mears and Helen Erlen have done some great early work in amongst their students and their subjects, and have noticed that some people read better with different colors, and I'm thinking of the overlays now. But it's not consistent again. Some like a yellow tint and read better, others like a gray or a blue tint. And the conundrum now, because this early work has been taken forward by the colorimeter and the workers who've worked with that instrument, to try and scientifically show the importance of color that Mears and Erlen first highlighted. Now, the conundrum is that these instruments, the colorimeter, and there's another work done with the chromogen lens, which is a contact lens, which was originally prescribed, different colored contact lenses in each eye, to see if it could restore the missing variable in people who are color deficient. Now, the results of that research never really amounted to a great deal, but what they did find is that in these fairly darkly tinted lenses, people read better, youngsters read better. And it's the same with the colorimeter. it's based on color preference, but it was found that the more saturated colors and seem to improve reading performance. So that's the conundrum. What is the effect due to? Is it the color or is it the saturation? And what we felt at that stage was a need to establish a simple method, if you like, of measuring color preference, initially with a fixed saturation tint. In other words, to get away from the confusion of having two variables, which is color and saturation. And we came up with the Eyebright test, which I'll just show you a picture of if this works. And I hope you're seeing that screen now. But it's 7 lorgnettes glazed with the colors of the rainbow, 6 colors of the rainbow, and neutral intensity gray. So that's what the original trial set looked like. Now I just want to tidy this away so I can find it again. So if I can just describe the test to you two, it's very straightforward, very simple. You have a subject and you say to them, now I want to measure your color preference, which will give me an idea how light sensitive you are. So I'm going to show you 6 colors in gray, and I want you to tell me successively which colors you like and which colors you dislike. So you say, what do you think of that? I like it. You put it on the right. How do you think of that? No, I don't like it. Put it on the left. And eventually you end up with 2 piles in the simplest description of the test. One on the right, which they like, and one on the left, which they don't like. And then in order to reduce the piles to the one they like the most and the one they like the least, you start offering fixed choices then. Now tell me, do you like number 1 or number 2? And the one they like best, you place on the right pile, and then try the next one, better with 1 or 2. And so eventually you eliminate the test to a pile, one color they like on the right and 1 color they dislike on the left. Now, in order to move this forward, we have 2 groups of athletes again. One, the netball panel umpires. These are the international umpires in Britain, all of whom are past netball players at an international or national level. And we also had data from the National Small Bore Rifle Association. And these are the junior national team, if you like. So these are elite athletes. And we took this test through with them. And this was done with the original trial set to see what would happen. And now I just want to bring back the slides again. Now, this is quite a busy slide, but I hope I can explain to you what it means. So you see the top red line, observed means those are the colors that were chosen, either as the best or the worst. And the colors of the set are teal, which is a blue-green color, yellow, which is pure yellow, blue, tan, an orangey color, gray, pink, fuchsia. Fuchsia is a blue pink color. And then people who liked all of them were one category and none were another category. Now, the way the results are displayed there is to depict the total results of these 2 groups, the colors they liked and they didn't like, all added together. Now, the reason that pink and fuchsia are combined is because when they were on their own, there wasn't enough data to allow us to use the statistical test which this represents, which is the chi-squared test. You have to have a minimum amount of data so that when you look at the expected results below, those figures are greater than 5. and when they're not, you have to combine those two groups. So pink and fuchsia didn't meet the criteria, all or none didn't meet them, so they've been combined. But looking at the data, and this is the combined data for both groups, you can see that if you compare now, looking at the best colors for the top line, second line after observed, and comparing that with the worst colors, so that's starting 5, 34, 6, 21, and so on. When you go down to the expected results, now these are worked out from the observed results to see what would be predicted if color preference was totally random, if there was no particular preference. And if it was completely random, you'd expect the best results from that data to be 10, 27, 13, 15, 14, and so on, and the worst 10, 27, 13, and so on. Now, when you compare those expected results with what was actually found above, you can see, if you look at teal, for example, the worst color overall was 5 for teal. If it was a random effect, you'd expect 10 people to like that color, but it was only 5. And again, it was worst for 5 people, but you'd expect that to be 10. So those figures are different. Now, if you go to pink and fuchsia, then that's not happening. The expected results almost exactly mirror what was found. So the important conclusion from as you look at that, you eyeball that data, is that gray, pink, and fuchsia probably are fairly random. But if you look at the colors teal, yellow, blue, and tan, they're completely unexpected. Now, that data there is why when you work out the probability that color choice in these two groups of athletes was random, you can say that because the probability of that is way less than 0.05, that it isn't random, that color preference is definitely a personal choice. Now, I want to show you the next slide, which is just looking at the rifle shooters. Now, when you reduce the data, so you're only looking at one group, you have less individual results to compare. So for teal and blue, those had to be combined. Yellow and tan actually stood on their own, but to reflect the combination of the choice of teal or blue and match it with yellow or tan, the two were combined. And you could see that when it was done that way, and if you look at the expected results below, you can see that they're totally different for those two color groupings. The probability that those are random choices is very, very small. So they're not random, they're chosen deliberately. Now the greater most likely probability was with the shooters. They were 0.0000115 probability that they were random, so they're not random. Netball was slightly higher. But what was very interesting during the research is that how significant the color blue is compared with yellow and tan. These two colors were never chosen as two that they were liked. You either liked blue and hated tan or yellow, or you hated blue and you liked yellow. So grouping those two colors together like that wasn't accidental. Those are the most powerful colors, and they were mutually exclusive. So something's going on here which needs explaining. So from that data, we can say that color preference is not random, and the significant colors were blue, tan, teal, and yellow. And it appears that these color preferences are specific to the individual. And although the data didn't support it, it very nearly reached the point where we could say that these two groups of athletes were identified by their color preference. It was different overall in the two groups, but didn't quite reach significant. And therefore, it's possible to say that a color preference, where none is normally expected, could be indicative of a visual disability. Now, why should that be? Why should color preference be an indication of a visual disability? Well, the best example is comparing blue and yellow. And this is the most obvious example of someone who's naturally light sensitive. Why should someone like blue and hate yellow? And when I say hate, I mean, you bring yellow towards them, they say, don't come anywhere near me with that color, I'll be sick. So they hate it. Now, the significance of blue is that it's a yellow absorber. Yellow is at the peak sensitivity of the visual system. And if someone is naturally light sensitive and you suddenly fill their world with yellow light, they hate it. But give them a blue filter and they love it because it absorbs yellow light. Now, why should it happen in the opposite direction? Why should someone like a yellow when they don't like blue? Well, the characteristic of a yellow tint is that A, it absorbs blue light. And blue light, what causes a veiling background haze in the visual system, because blue filters absorb UV and blue light. UV fluoresces in the normal eye, and also is focused slightly in front of the retina. So it's a confounding illuminance which gets in the way of clear vision. So if someone, for instance, has already got compromised contrast sensitivity, they will like a yellow tint because that sharpens up their view of the world. Now, why should someone have a compromised contrast sensitivity and an otherwise fairly normal eye? Well, think of visual development. Think of the hyperope or the person who cannot accommodate, how they manage life to start with. They can never see properly at the near point. So they never develop that fine contrast sensitivity, which you would if you can see clearly, because the brain simply can't tune into it. So they would tend to choose that yellow tint. Now, blue, on the other hand, is an indication of strong light sensitivity. And what we found from research over the years, and which I'll be talking about again tomorrow, is that light sensitivity is related to binocular vision. If you can't see writing clearly or comfortably, if you're putting lots of visual effort into that, the last thing you need in your eyes is a bright light, because the whole system then breaks down. It's the straw that breaks the camel's back. So we've identified two different causes of color preference. One is a binocular deficiency, and the other is a developmental deficiency. Now, this begins to explain why the Erlen overlays work. Some children will like yellow because it improves contrast. Other children will like blue and gray because it stops the reflected white light coming off the page, upsetting their light sensitivity. So both sets of children, for different reasons, will read better. Now, this is the point at which the colorimeter took over the research. And what it found, and this was amazing in its own way, is that when people were allowed to choose using the colorimeter their preferred color and saturation, those who chose fairly saturated tints, and these are going down to LT, let's say 40, so they're quite dark saturated tints, just like the ones with the chromogen lenses, they read faster. Now, originally, because it's very difficult to explain that, it was thought that it was because the color in some way diverted the visual pathway to a part of the brain which was not hypersensitive. The thought was that if the normal visual pathway took the light and the visual information to this part of the brain which is sensitized, suddenly you wouldn't be able to see that you get visual stress. And along the way, these subjects were also often identified as being dyslexic. Now, the misunderstanding of the cause of this improved reading speed has led to the belief that people with dyslexia who have visual stress have it because of this hypersensitive part of the visual cortex. So this is a very interesting problem, and the reason why it's happening is quite important to our understanding of dyslexia. Now, another aside, this comes way back in physical optics from the binocular textbooks, is a phenomenon which we use at times, or did use, to try and gauge the depth of suppression in someone with amblyopia, maybe a squinting eye. And what you do is present an increasingly dark tint in front of the good eye until the bad eye takes over. So you either get the good eye switching off and the squinting eye taking over, or you get both eyes trying to work together and you get double vision. So the principle of an increasingly dark tint raises the possibility that a similar process is going on with these dark tints that come from the colorimeter. And you might postulate that this is actually identifying a phenomenon which could be called differential chromatic occlusion. So as the tint gets darker, there will come a point when the weaker eye, the suppressing eye, will switch off completely. So the other eye just takes over. Now, what you're doing, in fact, is eliminating one eye from the visual process, and therefore removing the binocular vision problem which caused the light sensitivity and the reading difficulties from the situation. And clearly, if someone has a binocular problem and both eyes are fighting each other like this, then as they're trying to read a text, the words will be doing this, moving in the opposite direction, so you can't read them. So it's equivalent to just covering one eye and then suddenly it's all steady. So this is an explanation for why these darker saturated tints work. And it's an argument for saying we don't need to measure color preference at that level. Keep it to a fixed tint, a fairly light tint, which the set I showed is about light transmission 65, so quite a light tint. And not confuse the test with two different variables. That was the problem. Because now what we have is another explanation for visual stress and the increased reading speed. It's not impacting on a part of the brain which is highly sensitive. It's actually stopping the conflict between the two eyes, feeding to the visual cortex a very confused binocular vision message, which causes the excitement in the brain trying to interpret it. If you remove that conflict, the sensitivity goes away. In other words, it's not a congenital problem of increased cortical hypersensitivity, it's a binocular problem. Now, it's binocular, and you know what's causing it, a conflict between the eyes, maybe an unstable dominant eye. You can correct that with an ordinary pair of ophthalmic lenses and a correcting prism. For instance, if the right eye is the unstable lens, you know it wants to drift out there, you let it do that. And you put a prism in front of it, which bends the light in, so then the two eyes can work together and the problem is solved. We move the understanding of dyslexia from a congenital condition for which there's no cure except palliative care to a situation where dyslexia is treatable with ordinary specs and/or contact lenses, and occasionally using a light tint just to help that light sensitivity problem, which their binocular vision problem has predisposed them to. So it's a transformative effect. The importance of this is difficult to overstate because that's what optometry is all about. It's providing specs and contact lenses. And suddenly we have a method to help people with dyslexia. And I'm going back to a previous presentation where that lovely instrument measuring the way the eyes track and so on is a perfect example of children who will benefit from this approach. They can be identified by the tracking machine and then sorted out by an optometrist. There's no other referral necessary until otherwise proven. So this would, in a way, in a small field, and dyslexia is not a small field, and there are many, many ramifications which will come from that. But this is a start to introduce that possibility. So I just want to finish with this summary, if you like, that color preference is not random. It's dependent on binocularity, contrast sensitivity, and visual disability. Heavily saturated lenses have demonstrated this phenomenon, I think, called differential chromatic occlusion. And I would say that an increased speed on instruments like the colorimeter or the chromogen lenses is diagnostic of a binocular vision problem, which can be corrected with ordinary ophthalmic lenses and prismatic correction, and is diagnostic of a predisposition to dyslexia. So the machine is a very important development in the understanding of vision and its effect on visual performance. Now, if you want to learn a bit more about that, I've cited the article now at the bottom there. You just need to copy the title into the Google search net, and you'll come up with that publication, which I think goes into a lot more detail. It's such an interesting and important subject. I hope you get a chance to glance at that. And there we are. Thank you very much for listening.
Thank you very much for your presentation. So, Dr. So do we have any questions for Dr. Griffiths? Everything was actually neatly explained, so I don't think so there'll be any questions. So
Thank you. I'll take that as a compliment.
yeah, sure, definitely. So yeah, let's move on to our next presentation in that case then. So we actually have Dr. Eason from Harvard Medical School, USA, but due to some schedule conflicts, he's unable to attend the webinar today. Maybe he might attend it tomorrow to give his presentation. So let's move on to our next presentation by Dr. Aisha Simji from Ophthalmic Surgeon, USA. Please click on the screen button. Yeah, perfect.
Hello, good morning. It is good morning in California. Thank you for inviting me to talk to the meeting. I'm just going to tell you something about my 40 countries I have visited for ophthalmology, and they are around the world. So we are going to go around the world in developing countries in 25 minutes. So here is the book that I wrote after I finished 30 countries. Because of my family medical history, I thought I was going to die, so I quickly wrote this book. But after I finished 30 chapters in this book, I wrote 10 more chapters which are available in computer. It says Hope inside, and it is available in Amazon Kindle. You can read it on Amazon Kindle or the bookstore in California, Barnes and Noble. I have gone to different countries, and you will see the picture of the different countries now. These are the different countries that are shown on the right hand side, and we will go from one, we will quickly go through that since there are 40 countries, and it is not possible for me to spend too much time on any one country. But I must say, everywhere I go, there are 6 important points we have to remember. One, more than once I have had local children rubbing their eyes just so that they get into the line to see me. They go through the nurse who is triaging and they want to see me, they just rub the eye because they know I have some food for them. So they make the eye red and they want to see me. And there has been times when I've sustained myself on a protein bar myself rather than eat local delicacies because that may not agree with me. I may come home a few pounds lighter, but I haven't succumbed to problems such as dysentery, which is more than I can say for some of my co-workers on the missions, especially Ethiopia. When I went to Ethiopia with the Rotary Club, 51 people from all over United States, and 19 got sick the very next day because of food poisoning. Then we have to take extra shoes. In many poor places, poor people survive by taking things away. If you have to sleep in a tent and leave your shoes outside your door, don't be surprised to find yourself returning home barefoot unless you have another pair of shoes. And each of us has the gift of eyesight, the gift of a medical education, and more. These trips provide a wonderful way that we can give back when we have been given so much. An open mind. Often times a trip will not go as planned as desired, so flexibility is important. And many times I have felt devastated by socioeconomic injustice of those who seek my help, and all too often limitation of time and ability to help someone with a brutally advanced condition can take a toll. And patience, minimal infrastructure and language barriers are the norm. Expect that some of our precious time will be wasted traveling to and from different destinations. I will go to different countries, starting from British Guyana, which I visited in December 1991. I went to Latham with Sir Raleigh International. And of course, needless to say, it is a very poor country, very poor resources. And I went through whatever I could do. But the shocking thing is one day I went into shower and there was a huge snake, must be some 10 feet all around the door of the shower. So that's the way it is. So I took care of that with the help. But at the end of the trip, a Prime Minister of British Guyana came to greet with a group of us from United States, thanking us, and they treated us with tiger meat, which goes to only very respected visitors, and snake soup that has eyeball floating in the soup. It was quite a deal for an ophthalmologist to see eyeball floating in a soup made with snake meat. Then I went to El Salvador, Feudum Rosales Hospital in El Salvador, Santa Ana. And I was working there and I was taken there. There was, of course, no motel, hotel. I just stayed across the hospital with someone that local people. They accommodated me. I slept on the floor on a foam mattress, and I went to the hospital every morning, and I worked there for 10 days. And interestingly enough, I was surprised that why should I go through big door and barbed wire, etc., etc. But I was told by my organization, sending organization, not to ask too many questions about the surrounding because we don't want them to feel that we are too inquisitive. So final last day I asked, I said, where am I working? Little did I know I was working in Santa Ana, Salvador prison. They were all patients that I was taking care of were prisoners. And one patient I will never forget, it was approximately 15 years old, Jorge, his name, and he has bilateral cataract. I removed cataract from one eye, and then I was curious as why a 15-year-old should be in prison all by himself with both eyes cataract. I was told that there was a time when Salvador was going through a lot civil riot, and children, teenagers were given guns, and they were told to go and hurt people as much as they could, otherwise they won't get their meal. So this young guy, Jorge, was going around with a gun, hurting people, and then his eye, he got trauma, and he had traumatic eye. Unfortunately, he had both eyes cataract, but I did try to help him with one eye. Then I went to with Project Orbis, which is organized in New York, and the name of the sending organization is Project Orbis. It's a big plane and aeroplane, and that plane goes from places to places in the third world, developing country, I should say, and help them. And I was invited to go on that plane, so I did. But interestingly enough, when I landed in Bangkok, there was a huge monsoon rain going on, and they said they could not connect the plane to the electricity or water supply, and therefore they took me and all the supplies from the plane to different hospital, 3-4 different hospital in Thailand, and I ended up working there. And that the hospital I worked more than others hospital was Fudum Rosalis Hospital. It was very interesting. A lot of young ophthalmologists trained in different parts of the world, and they were there. The biggest problem is lack of resources, unfortunately, and that is anywhere I go, I see some qualified people, but lack of resources limits their activity. Then I went to Vietnam in 1995, Ho Chi Minh City, and I worked there in Vietnam, and I saw a number of patients that I did cataract surgery. That was not a big problem. I had all my supplies with me, all portable supplies with me, and there were some children, especially children, who needed cornea transplant. So I went to the hospital administrator and I said, you have a hospital, I'm sure there's mortuary, if I can remove the eye and the cornea and transplant these in the children, that they can get some vision. So they said, no, this is not acceptable with local culture, and this one was in May of 1995. It is not acceptable. They said you have to go and talk to the monk. So I went to the monk and I told the monk if I can remove the eye from the dead corpse and cornea, and then I will stitch up the eyelid so that no one can see that the eyeball is missing. And he says, this is not acceptable. This is not our local culture that you remove the eye from the dead bodies. And I said, well, I can talk to the family members. But he says, no, this is not the local culture. So I called my homeland in Baltimore, California, Baltimore and California Eye Bank, and I explained them the situation, and they called Sydney, Australia, and 2 people from Sydney, Australia brought corneas, believe it or not. They brought cornea, and I was able to do some cornea transplant in children, and I was satisfied. Especially, I ran into a doctor, Dr. Trent, who was a young woman doctor trained in Moscow, very much interested in doing cornea transplant, and I was able to teach her how to do a cornea transplant, left some of my instrument so that she can continue to do that after she can convince the monk that this is a very very interesting and very useful procedure that children can see at least better than what they used to see before. After Vietnam, I went to Republic of Georgia, that is USSR, Kutaisi Mountain, through United Methodist Church. That was also very interesting. Again, there was one woman ophthalmologist, very well qualified, trained in Moscow, but lack of resources was the problem, as usually. Then I went to Armenia in May 99. Armenia had a lot of educated, intelligent, well-trained people, and I thought I'm going to take some cornea from California. So California Eye Bank donated cornea, and I took it over there. But lo and behold, with all my portable instruments and slit lamp and indirect ophthalmoscope, etc., etc., I was not able to take the cornea in a box. It was under nutrient material, and I was not able to go inside in the city. And they said that they were confused. They were not bitter. They were not mad at me. They were confused. A woman doctor bringing a whole lot of corneas and eyeball in a box, and they didn't know whether they should let me go ahead or what to do with it. So they thought they will have a meeting. So they left the eyeball, cornea and eyeball box on the desk, and they thought they will have a meeting. So they went inside having a meeting. I took the box and I ran out of the door, and I took a taxi, and I said, if they follow me, that's fine, because I'm going directly to the hospital and hand over this box to the hospital administrator of the Armenian Eye Project, Malayan Eye Hospital, which I did, which was very daring, but I'm glad I did it. They did not follow me at all. And even if they followed, the eye was already with the hospital administrator hand. Then I went to Romania, Bucharest, Bulgaria, Bosnia, all Eastern European countries. Again, intelligent, educated, well-trained people, but no implant. And you can't just go ahead and do cataract surgery without implant placed in, because a patient will end up getting, having to wear aphakic glasses and not very convenient. I went to Philippines, Cebu City, which was easy to work with. Filipino doctors were there, and they were delighted that I'm there, and I was able to do quite a bit of work. Then I went to Nepal, Kathmandu, and I was supposed to work on about 10,000 feet higher in the mountains. But unfortunately, the place I was supposed to work with, the doctor I was supposed to work, there was a big malaria outbreak. So I was told I took Melaron before I left, and I thought maybe after I take Melaron, I will be able to work there. But they said no, the whole place is full of malaria. A lot of people are losing their life because of malaria and inadequate treatment, and therefore I couldn't go. So I ended up working in Koirala Eye Hospital, which is right downtown in Nepal, right downtown Kathmandu. But I was satisfied that I was able to do something instead of just returning because of this malaria. Then I went to Afghanistan, Kabul. I was somewhat emotional at that time because I lost my adopted daughter on 9/11 in New York, unfortunately, and I was emotional at that time, and that was in year 2002 in 2002 in Kabul hospital. Where I went there in Noor Eye Hospital in Kabul with Hope Worldwide Sending Organization. And it was worthwhile. They have a lot of patients who need cataract surgery and cornea transplant and other eye surgery. But I did the best I can working in Noor Eye Hospital. They had medical students. They wanted to learn, and I did whatever I can to teach them what they could learn and do with their limited resources. Then I went to Ethiopia, which was very interesting. I went with Rotary Club of Pittsburgh, Pennsylvania, 51 of us. The very next day, 19 got sick, including a nurse who came with me from California, and 19 got sick because of food poisoning. So they couldn't work, but I continued to work. It was very, very interesting to work in Ethiopia, Eritrea border. And then I went to Sri Lanka, Simigama, soon after tsunami flood. Very little could be done over there because there was no hospital. They were all flooded, and people were sleeping on the floor. And I just did examination, but I couldn't do any surgery because it was just not possible to do surgery safely. So I did just external eye examination, infection, etc. Then I went to India, Bhubaneswar. That was Kalinga Eye Hospital, which is very close to Calcutta, and very interesting. The Kalinga Eye Hospital, and there was another hospital in South India that does the largest number of cataract surgery in the whole world. They do about 400 to 500 cataract surgery every day by 30 ophthalmologists in different part of that area. And then I went to, I am from Burma. I grew up in Burma. I'm not Burmese, but I'm from Burma, and I went to Burma and I work in Sitagu Ayudana Eye Hospital, invited by the local monk. And I got along very well with the monk because I'm from Burma. I spoke the language, and I was able to do quite a bit of help over there. Then I went to Egypt in '07, Alexandria St. Mark Hospital in Coptic Church, and it was very worthwhile to go over there, work there. And a medical student from California who is Egyptian, he came along with me, and it was quite a good trip. Coptic Christians and the priest of that Coptic church was very pleased. He came and he thanked me profusely. Then I went to Colombia, Valle du Par, in Rosario Pumarejo Hospital, Colombia, that is in South America, and that is something that someone who wants to go to Colombia, please, please, please contact me, and I will warn you about few things I saw in Colombia that I don't want to say now in a meeting. And then I went back to Afghanistan. This is the only country I went twice because of what I saw over there and what they needed, and I just couldn't wait to go back. So that is the only country I went twice. Then I went to Cambodia, Lion Sight First Eye Hospital in Che Cham near hospital. And that place is also very, very poor, and many patients who needed help, but I did whatever I could. Then I went to 2010, I went to Haiti, Port-au-Prince, and I work in Sean Penn Clinic. Sean Penn is a movie actor in California, United States, and Jenkins Penn Haiti Relief Fund. I work over there. Sean Penn and his lady friend and his daughter, 19-year-old, 16-year-old boy were there, and we all stayed in the tent outside the country club because everything was destroyed. Even the hospital was destroyed with tsunami and earthquake, and I work over there with local people, and very little surgery could be done, but I did the best I can. And here I'm an ophthalmologist. I'm not supposed to touch the nose in between two eyes because I am only ophthalmologist. But over there, I ended up delivering babies, two babies, and very interesting culture. Whoever delivers the baby has to name the baby. And finally, a nurse from New York wanted me to name the baby with his name, Brandon. And the mother speaks only French. She says Brandon. And the nurse said, no, tell her to learn to say Brandon, not Brandon. Otherwise, we'll take the baby away. And then I went to Pakistan, also Islamabad, through Shine Humanity in flood relief project. Then I went to Peru, Juan Cavelica, with a group of students from United States, California. And I went to Ghana, Accra, what was very much worthwhile. There was a very good doctor over there, and a doctor from London was there. And we did quite a bit of surgery, actually. And of course, and needless to say, local nurses and young doctors wanted to learn few things, which I was able to deliver. Then I went to Latacunga, Ecuador, with ARPAN organization, that is the sending organization. Ecuador was also difficult because of a lack of hospital facility, but we did whatever we could in the temporary place that was set up for operating room. After that, I went to Jordan, Syria border, Salam Cultural Museum, which is a medical, but they turned into, it's a Salam Cultural Museum turned into medical mission, and I worked there with local people, and it was said a lot of refugees were there, Syrian refugees were there. Then I went to Fiji Island and Tanzania, and again Lebanon, Syrian border, but it was very difficult because we were working in a little camp. And then I went to Burma. I am from Burma, grew up in Burma in the United States for 50 years. I went to Myanmar, Rakhine with a group of doctors, and it was very much worthwhile to do surgery over there. and I was able to do because I know the local language, local monk, etc. Then I went to Jerusalem, West Bank, an Ethiopian refugee camp in Jerusalem, and that was very interesting in the sense that they had excellent doctors, and I have never seen an African rabbi, a rabbi originated from Africa, and he was there, and he gave me a hand, helping me with whatever I needed. Then I went to Malawi, Blantyre, Lion Sight First Eye Hospital in Queen Elizabeth Hospital. I don't know if Queen Elizabeth knows where Blantyre is, but anyway, that was the hospital name, and I worked there. Puerto Rico was another thing that was very difficult because there was a Puerto Rico earthquake, and it was very sad that I saw many children who could have been helped by pediatrician, but and there was no hospital at all. Everything was set up in country club, front yard, backyard, and the structure was torn apart. But we worked in the camp. Then I went to Bangladesh, Rohingya. Rohingya located on the border of Burma and Bangladesh. And then again, I went to Lebanon, Bakka Valley with Al-Zatri camp with a Med Global organization. So there's always a sending organization and the receiving organization, and they have to coordinate. And I don't mind telling you, it was my delight that I paid for my trip, I paid for my stay, everything except Project Orbis. Project Orbis is the only organization that pays for the trip and for your stay wherever you go. But all the other places I went, 39 places, I paid for my own trip, my own sending organization gave me supplies for some $30,000 to $40,000 worth of supply, and I'm glad I was able to do that. Now I want to show you some very quickly some photos of different here. This is a trauma, and we couldn't trauma, and I couldn't do anything. It was ruptured globe and retinal detachment, and I didn't have any retina specialist, so I just closed the wound. And this is I don't know what exactly it was. That's a fungus infection on the head, and I didn't have any medicine, so I just, you know, I advised local people to cut off his hair at least and remove some of the skin because we didn't have anything. This is a young man. Again, you can see very easily the right eye is completely gone, and he has multiple other medical problems. This is another man, right eye is completely gone and needed cornea transplant, but I had no cornea transplant. Otherwise, I could have helped him. This is trauma. I think this one was from Syria, and bad trauma. And you know, we did the topical suturing, and the eye was then placed under antibiotic. And this again, congenital abnormality. Both eyes were just couldn't keep the eyes straight, and I couldn't help the patient. And this is in Afghanistan. This is Afghanistan. This is herpes in the nose area, and there's another medical condition, and I was not able to help, but I'm glad that the herpes did not get into the eye. And this is Jordan, border of Jordan. This is me and the other doctors who are working with me, and they all work very hard. And this is Med Global medical campaign in Afghanistan, and there were so many children, and they were all wanted to hang around with me because I had some granola bar and chewing gum for them. And here, this is also border of Afghanistan, and this little girl wanted to come with me. She wouldn't let go of me, following me everywhere. This is a pediatrician, and this young Afghanistan, and her footwear, both 2 feet and legs were congenital abnormality, and I couldn't help much. This is in the tent. This is a Syrian border tent, and this child has multiple abnormality, including eye, but I didn't do anything else than just give antibiotic to treat the eye for infection, but multiple other problems were there, and snake was running around. This is herpes zoster, and both sides, which is very unusual for herpes zoster to be on both sides, and then herpes simplex, and I didn't even know exactly what was going on, but the eyes were eyelid were infected, eyeball were there. This is another patient, extremely uncomfortable all over uh, the face and hands. This is a young guy in Myanmar, and he's carrying the water from the water side. This is also in Ethiopia, and the child had a large rhabdomyosarcoma, and I don't exactly know what the pathology was, but it looked like rhabdomyosarcoma, untreated, and the child had this problem, and I didn't touch the eye because there's no radiation, no chemotherapy, and I think I would be hurting more doing something without any extra help. And this, both eyes were gone. Both eyes had corneal opacity, both eyes has cataract, both eyes has a limbus vascularization extensively. This was a place in Africa. This is again in Africa, one of the places in Africa. Patient has, I believe, rhabdomyosarcoma, but exactly what happened, I don't know. And I was not able to help because if I don't know exact pathology, and no use removing it and causing infection, since there were no antibiotic available for me to give to the child. And this is, one eye is completely gone, and the other was also infected, but I didn't do except I removed a part of the infected tissue and sew up the eyelid and put some antibiotic. This is Africa. I work with a group of doctors in Africa, very enthusiastic. They wanted to do whatever I tell them to do, and extremely interested and enthusiasm. And this is sarcoma of the muscles, and perhaps associated with squamous cell carcinoma, but I don't know exactly. There was no pathology involved, and I did not want to do anything till we get some radiation or chemotherapies to see what is going on. And I promise that the doctor who comes next probably will be helping you. And this young child in Africa, both eyes were gone, multiple problem, infections. This is very unusual. This is this is a man in Africa, one of the nations in Africa, and he is paralyzed. He has both legs are paralyzed. I don't know why, but anyway, he says he has been like that for a long time, and he was riding this bicycle, and his wife is completely blind. So he's riding the bicycle, and his wife guiding the bicycle, and his wife is pushing the bicycle because he couldn't use his feet for the bicycle. And again, a child with perhaps infection over rhabdomyosarcoma, and I don't know exact pathology since we have no pathology involved. And both eyes were infected, both eyes again infected, suppurative infection, and just plain antibiotic. This is again right upper lid is swollen, very soft tissue, and I don't know whether it was lacrimal gland tumor or sarcoma of the muscles of this area. I do not know, but I didn't touch it because I just didn't think I would have enough help after removing the eyelid or eye. Again, trauma, cataract, both eyes are gone, infected. Left eye has only light perception. Left eye has had no light perception. Right eye has only light perception. Just antibiotic. This is a large, the eyeball is popping out, and dad and mom were very upset. They said the child cries all the time, and since I did not know the pathology and I had no IV antibiotic, I did not do anything. I just gave topical antibiotic to hope that the patient will not get topical infection or ulcer, hopefully. But I didn't touch the eye. This is very unusual. First time I saw a rabbi from Africa who is now located in Jerusalem, and these are all Ethiopian refugees. This child is in Burma. The right eye is already gone, corneal opacity, and the child did not want to get out of my lab because he just followed me. She just followed me. This is a large tumor, and the right eye was gone, and I don't even know exact pathology, unfortunately. This is Burma, Myanmar, and I saw a patient in the in-between street and little tent here. This was flooded with monsoon rain, and I'm examining the patient in patient's backyard. This is again Burma. Both eyes were gone. Left eye needed triple procedure. Right eye is proptotic, and I don't even know whether it was a thyroid problem or trauma that he couldn't explain. This eye both hands were infected, and so was the eye. This is in Ghana. Both eyes are infected, cataract surgery, and a doctor from London was there, and we decided we just must not do any surgery since both eyes needed extensive triple procedure, which I was not able to do. And this is another child in Africa. He just couldn't get off me, and he's just curious because the child has not been held by someone for a long time, I suspect. And this is St. Joseph Hospital in Africa, and the nuns were very, very helpful to me, and they wanted to do anything to help me, but again, poverty and lack of resources. And this is in Ghana, in orphanage, and the children, as soon as they have some serious medical problem, they send the child to orphanage because the parents cannot take care of them. And there is a nurse from London who helps these people, and she has about 250 children, mostly children, in her 3 orphanage. And this is leprosy. Patient had leprosy in the eye that I'm very familiar with since I'm from Burma and I work in leprosy clinic. This is leprosy of the feet, and the patient also had leprosy in the eye, which is difficult to see because the eye may look normal, but the nerves in the cornea get very thick, and of course blood vessels starts growing, and very poor vision. This is leprosy in the hand. Patient also had leprosy in the eye. And this is again, this was in Ghana. Both eyes are gone, as you can see. Very little help, unfortunately. And this is Assembly of God Church in one of the South American country, and this is actually the church. And this patient had multiple problems: mouth and hands and nose, and also eyes. And this child was left foot was smashed in an earthquake, and it was both parents were gone, and the child was being taken care by another teenage girl who has a Foley's catheter, and the child she takes care of the child, and they provide her with help so that she can take care of the child. This is not her child. This young man came and cried. He says all he wants is one arm restored so that he can do. Both arms were gone in Afghanistan. And this girl is also in Afghanistan. The nose was smashed, gangrene, and she will obviously lose the nose. And she also, on top of that, she has multiple skin diseases. This is Syria, and I wish I could open it so that you can hear the song. They were Bashir al-Assad against Bashir al-Assad. This is a child who would not let go of me. And talking about all the other countries, this is in our backyard. I am a volunteer in COVID positive hospital in Orange County, California, and this is the doctor, and I was a volunteer. This doctor worked there taking care of COVID patient, and I was just doing whatever I could for their eyes and some psychological support, and I have to wear this, and I was carrying my own oxygen. And thank you very much. And if you have any question, please ask me. But if you intend to go to any of these countries I have mentioned, please don't hesitate to call me. My email is EYESIMD like in David AD@yahoo.com. I will repeat, ISIMDAD, EYESIMDAD@yahoo.com. Thank you very much for your attention, and do let me know, do ask me if you have any question and if you have any time.
Thank you, Dr. Aisha, for your presentation and
Can you talk a
letting
little
us.
loudly? Can you talk a little loudly, please?
Thank you for letting us know about your experiences. So, yeah, just wanted to know if anyone is having any questions. I guess there are no questions.
Okay,
So,
if there are no
thank
questions,
you.
they can always direct their question through email, and I
Yeah,
will answer through email, but they must include the email address so I can answer the question. And especially if you go to any of the country I have mentioned and that is shown on the screen, please do not hesitate to call me, and I will definitely help you with whatever I can.
sure. Thank you. Thanks a lot. Thank you for your time and your
Okay, you're welcome.
presentation. Yeah, thank you. So now let's move on to our next presentation. And the next presentation is from Dr. Enric Baj Quadra, CEO, Vision Brain, Spain. So yeah, your screen is perfectly visible to us.
Hello.
Yes, Dr. Enric.
Now it's okay.
Yeah, it's perfect.
Okay. Hello. My name is Enric Bach, and I am optometrist from Barcelona, Spain. I will be talking about the new ways of treating amblyopia without occlusion. Thanks to the organization for giving me the opportunity to be here and share our knowledge and our product with all of you. Speaking about amblyopia, and now I am speaking about the characteristics. At first, we need to discard pathology, and we need to know that it's a monocular disorder with a low visual acuity. Rate fixation, what kind of amblyopia is, and it affects the 4% of the population, and it's of course a consequence of something. And initially, monocular treatment is adequate, but not sufficient for the maintenance of the visual acuity after the treatment. The functional characteristics, the consequence of amblyopia are very different. You have the possibility to see in this screen the 5 more important: decrease the visual acuity, the contrast sensibility problems, increase of suppressions, of course, plus centrals, decrease fine stereopsis, and decrease the binocularity. And what should we promote in amblyopia? Visual acuity, it's necessary, localization, static localization and fixation, contrast sensitivity, binocularity, detection, movement, fixing, focus and accommodation, Another important thing is balance and the vestibular system work, visual discrimination, figure background, imagining or crowding. And of course, we need to integrate these all abilities. And the question is, and we only use occlusion? This is, for me, a good question for us. Arnold Hessel was a pediatrician and psychologist, and he said that vision is a motor, sensory motor. Moving is learning. It's important maintain care, and it's a lot of important integrates all senses, and we need to work with vestibular system. And what and how should we treat amblyopia? Movement, location, fixation, and these three parts, we need to work from periphery to central fixation, and we need to work the same way, accommodation, central fixation about cones, from periphery to center, eyeball. And it's very important, the dynamic ocular therapy. We need to work with movement of your eyes, movement of your head, with balance, with different things with visual therapy. And the vestibular nucleus plays a really important part in our eyes and head's movements and our physical posture. It analyzes all the information that we receive from our surroundings and help us act according to the circumstances. This is the main reason why therapies should be more dynamics, because movement and vision are closely related. Also, by integration vision, movement and balance, we will reach a much better automatization and a better maintenance of the results. Therefore, if we worked well, regressions are less likely to appear. How do we work with amblyopia with our products? Amblyopia is a big problem in our population, and we need to work monocular, biocular, and binocular therapy, from periphery to central, and integration of skills. And we need to work in different ways, in the clinic, of course, at home, and for example, exercising during journeys. It's very important, this part. And pursuits, saccades, attention, visual memory, sequential memory, consecutive memory, laterality and directionality, eye-hand coordination, visualization, visual closure, interhemispheric connection, visual discrimination, visual reaction time, accommodation, shape constancy, anti-suppression, and anticipation are specific and very important abilities to work with this type of patients. And how do we work with amblyopia? The need to work more and better with patients. Let me customize treatments. The conventional therapy is a manual therapy, and normally is slower and more expensive outcomes. Normally in my offices, I work with my patient with modern therapy plus conventional therapy. This combination, it's possible with artificial intelligence, and it's easier to do. You have the possibility to customize, and you have to mark success with your patients. Conventional therapy is very important in my office because exists the different type of exercise that it's impossible to do at home, for example, and we need to work with my staff in my office with this type of patients. But when we were working in a modern therapy, we have the possibility for our office and for our patients, of course, at home too. What is the main problem that we find while working with conventional therapy methods? Only we can't really know what the patient does at home, and they are stuck with the same exercise without changes to improve. It's very difficult to change when the patient is at home, and we don't know for how long they work. The new technologies allow us to know exactly what they have worked on, for how long, how they perform, the number of repetitions, and the most important thing about all, this is that they work at home exactly like how they work at our office. Moreover, we can use new technologies to work with several types of patients, from people with academic problems to others that just need to improve some of their abilities, like pilots, athletes, and other type of patients. As soon as you can clearly see, this person worked in this part 34 days out of 38 possible, which left with almost 90% of work done. This proves that in the majority of cases, working with new technologies encourages people to work at home. When working with modern treatments at the office, we can simulate and level with whatever stimulus that we choose, from number to letters, words, drawings, or even PED, different laterality letters. However, when the patient does the therapy at home, the artificial intelligence takes over the exercise, and depending on the person's performance, it increases the difficulty or makes it easier to help the patient improve. And this is the one of the ability. For example, you can choose the ability, you can choose the game in this case, and you can choose the different the stimulus total number, the good number, the scale or size, and you can personalize whatever you want. What kind of movement do you like, and what kind of stimulus do you like to prefer to present to the patient? And this is very important because the variety that is in the application is very important. And in this case, you can see as we improve all these visual skills, we are achieving both an improvement and a stabilization of visual acuity, decreasing regressions when finishing the treatment. This is an example of different levels, for example, of anti-suppression procedures. And at first, all the patients need to work from low level to high level. It's not the same when the patient is working with 3 letters, that like a letter butterfly with different type of size, number of columns, and the number of the total letters. And in the office, we can also work with virtual reality. It's very important. This allows us to play around with the central fixation. We can play, we want the patient to train, and with what eye he or she will see the stimulus, the distractors, or the guides. In this case, the left eye have the possibility to see the stones, but the right eye, it's impossible to see stones. Only to see the stimuli about with the hand. And in this case, when you need to work with amblyopic eye, with anti-suppression, with memory and ocular motility and eye-hand coordination, you can choose what eye need to see, what kind of, what quantity of stimuli, and you can see the right eye see different stimuli the left eye. And you work with anti-suppression, and now the patient is working visual memory in this case. And in this office procedure, we can see that with the right, another example of the anti-suppression work, with the right eye, with the patient see the gans, and with the left eye, he sees the fish. The size of the fish can be altered depending on the level of amblyopia of the patient. And as mentioned before, working on ocular motility, eye-hand coordination, attention, aim are very important integrating abilities. In this exercise, the bow is seen by the right eye, but the arrows and the bullseye are seen by the left eye. In this case, the movement is guided by the left eye because it's the one that is able to see the target. Thank you very much for your attention, and I hope that you like it. If any person has any question.
So thank you. Thanks a lot, Dr. Hendrik, for your presentation. So yeah, do we have any questions? I guess there are no questions. Anyways, it was informative, and yeah, it was good listening to your talk. Thank you. Thanks a lot for your presentation.
Okay, thank you.
So, thank you. So as we have done with our today's session, so let's all meet up again tomorrow. I hope you all have the link for the webinar tomorrow. So yeah, we'll see you again tomorrow. Thank you. So I hope you have checked the timings for tomorrow. So the webinar starts at 5 p.m. in London time. So yeah, I hope to see you all tomorrow. Thank you. Have a great day ahead.